Wait, am I sharing the right thing? I'm not, am I?
I see a welcome slide.
Okay, so I am sharing, okay, got it.
Looks good.
Okay, great. Then we can start. Okay, well, welcome back to day 2 of the practicum. We have a full schedule today and great sessions on efficacy and safety, rigor and reproducibility, and then breakout sessions. Please remember to take a look at the agenda, especially on how to decide on which breakout session you would like to attend later on. So thank you to all the attendees yesterday for submitting so many great questions. This really adds so much success to the practicum. Please continue to submit those questions today. And just a reminder, please put technical questions in the chat box, and please put questions for the presenter in the Q&A panel. So our first session, assessing the health effects of supplement ingredients, will be moderated by Dr. LaVerne Brown. Dr. Brown is currently a program director at the Office of Dietary Supplements, where she's interested in research that explores the impact of dietary supplement use on resilience and health in diverse populations. So thank you, Dr. Brown. Please get us started.
Great, thank you, Jamie. Welcome everyone to session 3 of the 2023 Mary Picciano Dietary Supplements Practicum. For this session, we've invited 3 scholars who will all share their perspectives on assessing the health effects of supplement ingredients. Each speaker will present for 30 minutes, which will allow 15 minutes for Q&A. And as Jamie mentioned, please don't forget to submit your questions to the Q&A box. So our first speaker is Dr. Joe Betz, who joins us today as a special volunteer, but previously he was the acting director here at the NIH Office of Dietary Supplements from June 2018 until he retired in December 2022. And prior to serving as acting director of the Office of Dietary Supplements, Dr. Betz was director of the ODS Analytical Methods and Reference Materials Program from 2002 to 2018. Dr. Betz's full bio is available on the Practicum's website, but I'm looking forward to hearing Dr. Betz's presentation entitled Doing the Studies, the Different Types and What They Tell Us.
Okay, good morning, everybody. First thing I have to tell you is I changed the title of the presentation just a little bit. And I also gave credit to Dr. Mary Hardy, who I present a similar talk yearly at the Scripps Natural Supplements Conference, and she helped me go through some of this stuff. So the new title is Reading the Studies, What the Literature Tells Us. So the first thing is neither I nor Dr. Hardy have any relevant disclosures about anything in this talk. So nobody's paying us under the table to say nice things about their supplements. And I'll start with an observation. Werner Heisenberg was the famous author of the Heisenberg uncertainty principle. And he very famously said that what we observe is not nature itself, but nature exposed to our method of questioning. Once we poke something, we tend to change it a little bit so that what we're measuring is now no longer what we think we should be measuring. So that the perspective difference shows from these polar bears who are one day going to be seeing the world from outside the ooze. So mainly this is a little bit about how not to get overwhelmed by the literature. It's easy enough to do if you start digging into things. And as I mentioned, some perspective. First, a regulatory summary. The FDA speaker did a great job talking about the regulatory situation for supplements yesterday, but I will remind folk that there are different regulatory philosophies surrounding the two different categories. Drugs are intended to cure, treat, mitigate disease. They are unsafe by definition until a sponsor proves otherwise to the FDA. They require pre-market review and approval by FDA for efficacy, safety, and also quality assurance. And there is an investigational new drug application process, not to be confused with the NDI process, which was spoken about yesterday. Once a new drug goes through the process, there are mandatory formulation standards that manufacturers must meet, and there is product registration so that FDA knows what's on the marketplace. Supplements are intended to supplement the diet. That was presented yesterday as well. Supplements are food. Therefore, they're safe by definition unless they're new dietary ingredients. So that contrasts with the drug situation where the drugs are unsafe by definition until they're proven otherwise. There is limited pre-market review. That NDI process was about it. And there's no pre-market approval. There are no mandatory formulation standards, and there's no product registration. Just a couple of cautions. One is that when you're reading the literature, you have to have some situational awareness. There are such things as predatory journals. These are journals where you pay a fee to get open access, and there may or may not be actual peer review that goes on once the article is submitted. This article was published in 2017 in BMC Medicine, but the problem was more long-standing than that. The problem predated 2017 by quite a lot. Just to show that this is still an issue, this was just from Science this year. Fake scientific papers are alarmingly common. This particular article notes that up to 24% of biomedical research is fake or plagiarized. There are some caveats in certain types of studies. So if you're interested in antioxidant activity, there are at least 2 journals. This is one of them that will not accept papers that use in vitro antioxidant activity as their primary outcome or endpoint. Those papers will be rejected out of hand because in vitro antioxidant activity of the compounds has not been convincingly observed in vivo. So these 2 basically food journals take a very jaundiced view of antioxidant claims. There are also retractions. Some investigators are more active in the retraction area than others. So this particular researcher who was the subject of this article, the URL, the huge URLs down at the bottom, and you'll have these slides if you want to look this up. But you'll find that as with the fake papers and the predatory journals, there are investigators who fake data and get it published in legitimate peer-reviewed journals as well. So these are just some cautions to keep in mind, keep in the back of your head as you're going through any article in the literature. So the research questions are these. NIH was interested primarily in the second bullet point, does the intervention work? And also if it's safe. Originally I had those first two bullets reversed, and then I realized it's unethical to do the second bullet unless you do the first bullet first. So the questions are, is it safe? Does it work? And how does it work? When we're talking about human studies and the evidence, this is the evidence pyramid. Way down at the bottom are the in vitro test tube research. And just above that are animal research, clinical judgment, etc. This is not intended to be judgmental. We do look at randomized controlled double-blind studies as the pinnacle of quality research for humans. But the reason this is shaped like a pyramid is because to get to that randomized controlled double-blind studies, you don't just happen upon a clinical trial design or a drug. You go through all this other stuff first. So these support the final design of the clinical trial at the end of the day. So this top area, the peak of the pyramid, would not be possible without the other supporting elements of the triangle: animal research, in vitro research. If you're going to make a claim and you try and use in vitro or animal research as the basis for justifying your claim, I will tell you that the Federal Trade Commission will probably be all over you if you're a manufacturer and try and substantiate your claim based on animal or in vitro research. There are a couple of different types of trials, and they differ in size and their intent. So I'm going over this because so that you have a little bit of perspective as we talk about the rest of the things that we have to consider in a trial. So for a new drug approval, you get through the preclinical animal studies, and then you do a phase 1 trial in humans. Phase 1 trial is intended to establish safety and dosage, so there'll be often dose ranging, looking for adverse reactions, and also pharmacokinetics. These trials are typically 20 to 100 people, healthy people, I'll note that, and they can take several months. Phase 2 trials are the next step up. They are looking for efficacy and side effects. These are the beginning studies looking for efficacy. And they're typically have up to hundreds of people with a disease or condition. And those studies last from months to 2 years. And then finally, the phase 3 trial is essentially what gets a product into market. It's efficacy and monitoring adverse reactions. That typically has 300 to 3,000 volunteers, depending on the endpoint. These are diseased people or people with a condition that you're interested in treating, and they can last 1 to 4 years. I didn't make this stuff up, so the URL there is down at the bottom is a nice guide. It's where I cribbed all this information from, and there's more information, including a video on that at that URL. But so this is just a little bit to give you an idea of why studies are done, the size and the time scale that we're involved. There's also a phase 4 trial, which is essentially a post-market surveillance for efficacy and safety. I didn't mention that because, those are, as I said, they're post-market rather than designed up front. Well, I said that poorly, but I think you get the point. So we'll talk a little bit about some of the buzz surrounding herbs, especially. I'm a pharmacognist by training, so I tend to revert back to herbs and plants. So Deshay co-occurred with a whole bunch of things in the 90s. This article from Time magazine talking about the herbal medicine boom, was in the same issue of Time magazine that talked about Bill Clinton, not Hillary, versus Saddam Hussein. So we're talking about the 90s here. And also this Life magazine was also from the 90s, and these are about herbs and the healing revolution. And these were based on some promising results for some clinical trials back in those days. A little bit of history. Up until about the 70s, there weren't a whole lot of modern clinical studies published. A lot of the information available was based on anecdote or folk use. From the 1970s onward, the European phytomedicine regulations led to modern studies and licensed products. And a lot of these early studies, published studies, were positive, and they studied the things, you know, the familiar herbs, black cohosh, echinacea, feverfew, garlic, etc. over on the right there. So we'll just pick on St. John's wort for a minute, and you'll note how old these these publications are. This particular one was from 2000. So here was a nice study. Let's see, 324 subjects. This is Zeller 117 St. John's wort. Zeller is a big German phytomedicine company. Quality assurance is quite good. And this was a imipramine versus St. John's wort study. They used the HAM-D depression scale for mild to moderate depression. And you see over the course of from baseline to week 6, both the hypericum group and the imipramine group, which is a tricyclic antidepressant, showed pretty good, pretty close efficacy. People got better. Another study that was designed because the first study investigated an old tricyclic antidepressant as the drug comparator. So somebody said, well, let's do it versus a modern SSRI, sertraline. And they did a small study, very small study, 30 subjects. Lichtvar 160 St. John's wort, also a very high quality German-made product, and that also showed some improvement from baseline to week 4. So we went along with those relatively small studies until this study came out in 2002. So it's not that long after the other ones, but this was a big NIH funded study, primarily the National Institutes of Mental Health, and this was a 3-arm trial. So this had an active comparator, which was sertraline. It had a placebo, and it had hypericum. And you'll see, as with the previous studies, the St. John's wort worked just as well, pretty much statistically just as well as the sertraline. People got better. But it turns out that so did the people on the placebo. The reason those original studies were designed with no placebo is because the European protocols consider it to be unethical to treat diseased people with an inert material like a placebo. So the trials tend to be an active comparator versus the intervention that you're interested in studying, because the placebo arm would be considered to be, excuse me, unethical. So this large study, let's see, I was trying to find the number of people in it, and you have to look it up, I'm afraid. But anyway, it turned out that sertraline and hypericum in this study anyway were just as good as placebo. So moving forward, we have to talk about study details and how they affect what you're doing. All sorts of conditions of things to consider. This is by no means a full list of things, of details that have to consider when you're both designing and also reading a clinical trial. What's the hypothesis and rationale, the type of study, whether it's a phase 1, phase 2, phase 3, what are your study outcomes, the endpoints, primary and secondary endpoints, what statistics are you using, a description of intervention and placebo, the population characteristics, inclusions, exclusions, etc. So we'll go through just a couple of these. I pick on a couple of these elements because they really help you zero down on the reliability of the studies. So we talk about the hypothesis and the rationale. So the hypothesis decides the dose and dosage form. So the dosage form could be, if the hypothesis is based on traditional use, You may give the person an infusion or a tea, as in traditional Chinese medicine, which tend to be multi-herb concoctions that are made into a tea, or versus 1 gram of root per day, versus 300 milligrams of a hexane extract 3 times a day. So these are different types of dosage forms and different dosages, and your hypothesis is going to decide what your material in the trial looks like. Hypothesis will also decide on the timing of the intervention. Continuous for prevention, at first onset of symptoms. That's characteristic of the echinacea studies that are in the literature. There are both in the literature. Some that look at people who are given echinacea daily in the absence of a cold, and others who start taking echinacea after the first onset of symptoms. So those are different endpoints for different purposes. What are the endpoints? Cure, reduce mortality, support healthy function, maintain wellness. So you might see the first two, cure, reduce mortality, in a drug trial, whereas in a supplement trial, the endpoints tend to be a little bit more fluid. I'll be generous and use the word fluid. But that has implications in the design of the trial. The method of assessment, self-assessment. So a lot of these echinacea trials that were done on echinacea, or for the common cold rather, were self-assessments. They used a log of symptoms. You know, how runny was your nose today? How many times did you cough? How many times did you sneeze? All that sort of things. The viral titer. Some of the echinacea studies actually tried to measure viral titer in the patient's blood. And for some of the pediatric studies on echinacea, the parents kept a log of the symptoms. So the method of assessment is going to affect the outcome of the trial as well. So let's jump into a traditional use, ginkgo. Ginkgo seed was best known as a traditional Chinese medicine. However, the compilation of essential items of the Materia Medica, published in 1505, classified ginkgo leaf in a similar fashion to the seed. Dried leaf was used in tea with other herbs. And this is where we start to get tricky with traditional use. The traditional system of medicine, of Chinese medicine, uses different diagnostic characteristics, uses different classifications of diseases. So the temperature energetics of ginkgo are defined as neutral. The energetic taste is described as sweet, bitter, and tart, and channel affinity extends beyond the lung into the spleen and stomach. Now, I am not a traditional Chinese medicine person. I'm a chemist by training. So if you want to have an interesting lunchtime conversation, talk to a Chinese traditional medicine practitioner so that they can explain all this stuff to you. But I'm just saying these words are different than the words one would use for a Western diagnosis and a Western treatment. The medicinal actions of ginkgo are cited as astringing the lungs, calming asthmatic wheezing, and halting diarrhea by transforming dampness. Sometimes locally used to improve circulation. So that's where we get into the more modern uses, is that circulation improvement. Consider what the trial designed to evaluate an endpoint of transforming dampness would look like. So if you're designing a clinical trial, and the endpoint is transforming dampness, what would that look like in terms of a clinical trial? What kind of outcomes, what kind of population studies, what kind of statistics would you need? Now, the modern use of ginkgo as a phytomedicine pretty much started with a homeopathic remedy manufacturer, Dr. Wilmar Schwabe. Company was founded in 1836. The company produced its first ginkgo biloba extract in 1965. It was made using a complex 17-step extraction purification process with solvents not available until the mid-19th century to produce a product or an ingredient called EGB 761. That stands for extract of ginkgo biloba, for those of you who like to know what the acronyms mean. And it was introduced for circulatory disorders. Okay, so there's a little bit of a nod towards the traditional use. The standardized extract is approved as a phytomedicine by the Germany's Commission E. Commission E was the special unit of bee farm that was set up to deal with herbs. The product was very highly standardized, very highly processed, and very highly studied. It was standardized to 24% flavanol glycosides, 6% terpene lactones, and less than 5 ppm glycolic acid. Most of the higher end ginkgo biloba extracts on the market try and look like that chemically. Okay, with the standardized flavanol glycosides, 6% terpene lactones, and a certain amount of less than a certain amount of ginkgolic acid. It was only improved in Germany for use in intermittent claudication because trials for other uses were either not performed or were inconclusive. So there's a limitation of this particular product. It was only approved for intermittent claudication, and yet you'll see it used for all sorts of circulation-related disorders. So we take a look at the ginkgo evaluation of memory study, which was a big study funded by NIH. This is not a traditional use. The idea was to look at ginkgo in terms of slowing down or stopping dementia. This was a multi-year study, median follow-up of 6.1 years. So the first publication, the first endpoint was slowing down or stopping dementia in the aging population. Big study, 3,000 community dwelling participants, old folk. The study lasted from 2000 to 2008 or so. The hypothesis mechanism, we talked about this, was improved circulation in the brain. The second endpoint, after the first dementia endpoint, was, does ginkgo extract slow normal cognitive decline associated with aging? The intervention was EGB 761, so it's kind of the gold standard extract, 120 milligrams twice a day, or an identical appearing placebo. The main outcome measures were rates of change over time in the modified mini mental state examination, cognitive subscale of Alzheimer's disease assessment scale, and neurophysiological or neuropsychological domains of memory, attention, visual spatial construction. The conclusions, compared with placebo, the use of ginkgo biloba did not result in less cognitive decline in older adults with normal cognition or mild cognitive impairment. So the first study, that's the one in 2008, the Kuszak study, showed no effect on dementia. The second study, Schnitt et al. In 2009, showed no effect on cognitive decline in older adults with normal cognition or with mild cognitive impairment. So that was the normal healthy aging population. And there are still sub-analyses going on. Simmons just published a paper this year that analyzes some of the data, looking at some of the secondary endpoints. So we'll talk now about the study outcome. What are the primary and secondary endpoints? What are the statistics? And we'll talk about some publications. So these are publications that have occurred in the early 2000s to mid 2000s. Echinacea for prevention of experimental rhinovirus colds, St. John's wort and major depressive disorder, effect of increasing doses of saw palmetto on lower urinary tract symptoms. So the first thing you'll note is that Echinacea for prevention of experimental rhinovirus colds. If you'll remember back to yesterday and to a little bit this morning, prevention of a disease is a drug claim. It's a disease treatment or disease prevention claim. So this study, even though it uses a material that's available as a dietary supplement in the marketplace, would really have to be classified as a drug study. The same as the second trial. These are treating major depressive disorder. This is the disease treatment trial, even though it uses a material that's available as a dietary supplement. And the third one is a little bit of a trick question. the third study used a dose ranging, and it had to be conducted under an investigational new drug application because the higher doses of the dose ranging study on saw palmetto were higher than the doses of the commercial products available. And if you know anything about FDA's botanical drug guidance, you'll know that you can do some things without an IND in early stages if the product's already available as a dietary supplement in the marketplace, as long as you use the material that's already available as a dietary supplement. When you up the dose, you change the parameters, you need an IND. So endpoints, echinacea to treat or prevent colds. What effect does the treatment have on the occurrence, duration, and severity of the cold? That's evaluated by a self-administered questionnaire. St. John's wort to treat depression. The instrument was a HAM-D score, and there was an interview by a trained health practitioner. Saw palmetto for BPH symptoms measured discomfort, urine flow, sleep disturbance. Again, there's pretty much essentially a diary, a self-evaluation. And these are for BPH symptoms. So remember, the phase 2 and phase 3 trials were done in folk who were either sick or had the condition that you're interested in. The dietary supplement studies, dietary supplements are intended to be taken by people who are healthy populations to kind of help ward off problems, to maintain health. So we're not talking about disease prevention or disease treatment. We're talking about giving these things to healthy individuals and see what happens. Echinacea to help support healthy immune function is a legitimate structure function claim that's allowed for dietary supplements. You're not treating a cold, you're not preventing a cold, you're helping support a healthy immune function. So then we have to talk about the occurrency and severity of what, because all of a sudden we're not talking about symptoms anymore. And you're using a self-administered questionnaire. So what would that questionnaire look like? St. John's wort to help maintain a healthy mood is a legitimate structure function claim. It's not treating or preventing mild to moderate major depression. So a questionnaire, a survey instrument might ask a question, are you happy or sad today, or something like that. You need to ask questions concerning a healthy mood rather than do you feel like killing yourself. Different sort of questions, different sort of questionnaire. Saw palmetto extract on lower urinary tract infections or lower urinary tract symptoms. The same are true. Now, there's a bit of a trick question in here in that the first two, when we talked about the studies, echinacea for colds, St. John's wort for depression, saw palmetto is used to treat lower urinary tract symptoms, and FDA has kind of made a decision that lower urinary tract symptoms are conditions of aging. It's not a disease. So as long as it's relatively minor, then this is a legitimate dietary supplement claim, dietary supplement study. If it hadn't been for the higher dose of that study that I cited, you wouldn't have needed an investigational new drug application. Okay. Description of the intervention and the placebo. I'll spend a lot of time on the intervention and the placebo. What material do you wish to study? Taxonomy and naming the plant part are important. Dietary supplements require you to name the plant and the plant part that goes into your botanical dietary supplement. So if we're talking about Actaea racemosa, we're talking about black cohosh. There's a legitimate Latin binomial synonym for black cohosh, Semicifuga racemosa. German names, these are common German names and common English names. There's a number of common English names. So you have to make sure that you describe the name, you name the material that you're using adequately. Latin binomials preferred. In this case, it would be Actaea racemosa or at a stretch, Semicifuga racemosa. Black cohosh is acceptable because there's a provision in US law that allows you to use the common or usual name as published in the American Herbal Products Association Herbs of Commerce. That uses the name black cohosh as a synonym for Actaea rosemosa. These other ones are out. You would not be able to label a product, or you shouldn't label a product any of these other common names. Chemicals, I harp on about the taxonomy and the common names and the Latin binomials for herbs, but chemicals suffer the same things. These are some trivial names that have actually occurred on labels. If a company is interested in making their product sound exotic and magical, they will quite often pick one of these more unusual trivial names like guaranine to put on the label of their product. There's less of that going on now than there used to be, but it still happens. The accepted common name for this compound is caffeine. These are synonyms, and the CAS name, the Chemical Abstract Service name, is this long mouthful: 3,7-dihydro-1,3,7-trimethyl-1H purine 2,6-dione. So you got to make sure you get your chemical name right as well. I've seen this in a lot of nutrition studies where you get a vitamin E, that's the natural vitamin E versus some kind of a racemic mixture of synthetic vitamin E. If you don't know the isomer, then you don't know the chemical. This is important. I've seen the fair number of older studies that are not complete in terms of their description of the nutrient that's used. So back to the naming, back to the chemical composition. We can go into the dietary supplement label database. We can search for ginkgo, and we turn up 52,129 labels, 31.4% of the database, that have the word ginkgo somewhere on the label. If we click on the button that's for on market versus all labels, then we find 33,441 labels with the word ginkgo on the market. So we have some data from Jim Hornley over at USDA, who performed some non-targeted chromatographic analysis of ginkgo products. And he actually looked a lot more than these, but you can see that the fingerprints, I won't bore you with the individual compounds that are here. The fingerprints are very different from many of the products. So the first two at the top, the first one is the EGB 761. That was the gold standard. That was the Villmour-Schwabe product. There are some other products that were designed to look like that. So you can see kind of similar products in the first, or similar fingerprints in the first two chromatograms up there on the top. But then you see some chromatograms that have a flat baseline, or very simple chromatograms with only two tiny peaks. So the fourth one down has only two tiny peaks. And so you can see these products, even though there's only a handful of products, can look very different. And when you remember that there's 33,000 products on the market that claim to have ginkgo in them, you can see that those products may look very different. So if you're reading the literature and looking at whether EGB 761 does something or not, understand that the consumer walking into a store may or may not be able to identify the product that has EGB 761 as an ingredient. So they may end up with something else completely, chemically, botanically, very different. Remember, there's no formulation studies, or no formulation standards. So we'll highlight that from several slides ago. No mandatory formulation standards. These products are probably mostly legal, even if they don't look like the gold standard material. Companies are free to set their own specifications and then test against those specifications. And if they choose a specification that looks like one of the flat baseline products, then that's their specification, and the FDA can't make any judgment about that. Now we'll talk about placebos. This is a big bugaboo of mine. I started talking about placebos back in the 90s, shortly after DeShay was passed. There were some early studies on things like valerian root for nighttime sleep aid. And valerian is an interesting herb because it smells of goat and sweat socks. So if one is trying to design a placebo that is not going to immediately break the blind because it doesn't smell like goat and sweat socks, one has a hard time. And so that was the first example of placebo. You had a white powder versus a brown smelly material, and people who participate in clinical trials talk to each other. And so that blind was out the window almost immediately. So we talk about adequacy of blinding, herbs of characteristic odors and taste. Remember all this, we always have to keep this in the back of one's mind. There's large placebo effects for natural products. This leads to an underestimation of the number of subjects needed in a trial. And many studies end up being underpowered. You see many trends with no significance in a lot of these studies with a large placebo effect. So I'm going to conclude basically with a discussion of two trials, and these were on fish oil materials. Oops, sorry about that. So the two trials were Reduce It and Strength, and they were published back in, I think, 2019 and 2020 respectively. This quote comes from an article. It's essentially an editorial talking about the two studies. The data surrounding the utility of omega-3 fatty acid supplementation for cardiovascular disease are mixed, and aggregate results suggest no significant benefit. An outlier is the Reduce It trial, reduction of cardiovascular events with icosapent ethyl intervention trial. So that's from the editorial. So Reduce It was very promising. Showed the stuff, changed the relative risk and changed cardiovascular outcomes when this Vasipa was used in a clinical trial for cardiovascular disease. So here's the original study. Reduce It, reduction of cardiovascular events with icosapent ethyl intervention trial. And according to this study, the stuff worked. It's a study of Vasipa versus mineral oil placebo, 8,179 participants with diabetes or established cardiovascular disease with elevated triglycerides, plus whatever standard of care was being used. Background statins was usually what was used. There was a mean follow-up of 4.9 years. So this is a big study, a big expensive study. The primary endpoint was composite of cardiovascular death, non-fatal MI, non-fatal stroke, revascularization, or hospitalization for unstable angina. 17% of the treatment group were versus 22% of the placebo group showed a worsening of their cardiovascular symptoms. So the placebo group did not improve, the treatment group did. There was a significant 20% reduction in cardiovascular mortality from the Vasipa group versus the placebo group. Now, we contrast that with the strength trial, the statin residual risk with Epanova in high cardiovascular risk patients with hypertriglyceridemia. This study used a different formulation of omega-3s. The omega-3s, there were three omega-3s, omega-3 carboxylic acid ester, versus corn oil as a major adverse events. The primary outcomes were the same for this as for the other trial. So this was, like I said, a combination of the esters of icosapentaenoic acid, docosahexaenoic acid, linolenic acid, versus the Vasipa, which was just the ethyl ester of icosapentaenoic acid. So different formulation, different chemical formula, versus corn oil. This was an even bigger study. 13,708 patients at high risk of cardiovascular disease with background statins. The study terminated in 2020 due to futility. Nobody was getting better. Primary endpoint composite was the same. The scores were used, the endpoints were used as the same as in the Reduce It trial. Only you can see the statistics here, 12% of the treatment group versus 12.2% of the placebo group essentially had a reduced risk. So basically no effect. So this has spurred a cottage industry of editorials and commentaries about this. So early on, people were saying, well, you know, what the heck is going on? And people attributed the difference in the outcome to the chemistry of the materials. One was a single fatty acid, ethyl ester. The other one was 3 fatty acids, carboxylic acid esters, different, essentially very close to the same dose. EPA levels in the serum were the same, basically, whether one was in the reducer trial or the strength trial. So what was going on here? It's easy to point to and say, well, you know, this one type of chemical entity is effective and this other one isn't. But it turns out that people got thinking about this more and more and looked at mineral oil versus corn oil. There was even a study that was published in 2021 that went backwards in time, so to speak, and looked at an animal study. They did an animal study of mineral oil versus corn oil to see the effects on various biomarkers and risk factors. And they found that, in fact, mineral oil is pharmacologically active. It caused the leaking in the gut and pro-inflammatory action. So mineral oil has biological activity in it, and it's apparently detrimental compared to something like corn oil in animals. So this editorial was published in 2021. This is the one that I got that original quote from. And the conclusions were basically that, there's that quote again, sorry about that. So the conclusions were basically that when one looked at the outcomes, at the risk factors in the placebo arms and the treatment arms of the two placebos, they were very different. So the one on the left there, the placebo arm, the corn oil is blue, mineral oil is orange. Corn oil and mineral oil, pretty close to the same effect. There was a little bit of an increase in triglycerides in the placebo arm for mineral oil. A respectable size increase in LDL cholesterol, somewhat of an increase, about 7% or so in lipoprotein B, and a 30% or almost 32% increase in C-reactive protein in the mineral oil, whereas corn oil showed a slight reduction in triglycerides, LDL cholesterol, lipoprotein B, and C-reactive protein. And when you look at the treatment arms, you can see the differences, the outcomes for the treatment arms. So what it boiled down to was the people who are taking mineral oil were being made marginally sicker. I'll come right out and say it that way to make it clear, than the people in the corn oil placebo group. So that meant the difference between the two arms, between the placebo arms, were larger than they would have been if both studies had used corn oil. So this is my conclusion, and essentially the conclusion of Bostrom and his co-authors in this study. So caution about reading studies and looking at placebos. You have to be as careful picking a placebo for these natural products as you are with the non-placebo or with the intervention itself. So I'll conclude with this slide. General guidelines. The commercial universe is a pale and distant reflection of the peer-reviewed scientific universe. The scientific universe does not provide ready answers, but can provide some informed guidance if you know how to look and what to read. And the best evidence for categories, not products, not individual product, can be found in meta-analyses and evidence-based reviews. And I'll end there. I don't know if I left myself any time for questions or not. So there we go. I'll stop sharing my screen.
Thank you, Joe. I see comments in the comment field that you are a national treasure. So bravo for the very nice presentation. But there aren't much time for questions, although you have a few questions here in the Q&A box. We are wondering if the participants and you, Joe, might be interested in staying back during the break from 1:15 to 1:30 to maybe address those questions. You have at least 7, maybe even 8 questions. If if you and the participants are interested, we can.
Yeah, no, I'm happy. I'm happy to hang around. Yeah.
Great, thank you. So we'll move on then. We'll move on to the next presentation. Dr. Howard Sesso is our speaker for the second presentation of this session. He is an associate epidemiologist at the Division of Preventative Medicine at Brigham and Women's Hospital. He's also an associate professor of medicine at the Harvard Medical School and an associate professor of epidemiology at the Harvard T.H. Chan School of Public Health. He designs and conducts randomized clinical trials and epidemiologic studies focusing on dietary supplements, nutrition, and lifestyle factors to prevent cardiovascular disease, hypertension, and other aging-related outcomes. Today, Dr. Sesso's presentation is entitled Efficacy and Effectiveness, Lines of Evidence in Supplement Research.
Research and also Associate Director at the Division of Preventive Medicine at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. And it's my absolute pleasure to be here today. And I do apologize for being here as a recording as opposed to in person. I have the good fortune of having my daughter's college graduation at this time, so had a conflict that arose. Nevertheless, I have always felt very strongly in the benefits of this practicum and the breadth of learning that you get from it. And I hope that from my talk, you'll get a better sense of how efficacy and effectiveness ought to be considered very carefully as we approach dietary supplement research of any type. So, my background in dietary supplementation actually goes back to when I was quite young. I was about 11 years old at the time when I had done this really terrible art drawing and realized very quickly that art was not my forte, but rather eventually research, hopefully. But I think the question of dietary supplementation is always boiled down to how do we approach the American diet, namely through supplementation? And how do we use this to really understand what the benefits are? It's easy to equate dietary supplements with benefits in a very general sense, but we really need the tools of efficacy and effectiveness to really set the story straight and clearly delineate what the answers are to the research questions that we have. And this is particularly true in the clinical trial setting. Now, what typically happens when we think about a lot of the nutritional hypotheses that we have is what I call dietary reductionism. Typically, through a lot of tools such as nutritional epidemiology and food science, we start to identify foods and dietary patterns that might reduce the risk of major morbidity and mortality, things like cardiovascular disease, cancer, falls, other things. Now, when we look at the diet more broadly, we assume that those benefits might be driven by specific vitamins or minerals or nutrients or bioactives. Now, where dietary supplements have traditionally come in is we look at some of the work from nutritional epidemiology and observational research, and we ask the very honest and open question, can a dietary supplement capture these benefits in a way to meaningfully improve health? Now, one thing that has happened historically is that dietary supplement use often increases markedly before definitive randomized clinical trials of efficacy and/or effectiveness are actually completed. And if we take the example of the strawberry, it could be any food for that matter, we look at the strawberry and we can ask a few different questions with regard to that strawberry. We can look at the strawberry and simply say, Is it something about the food matrix, something about the food itself? What is it about the food that might derive benefits in terms of health? Or is it not just the strawberry? It's not the strawberry in isolation, it's the strawberry in combination with other foods, dietary patterns. Can this explain the types of health benefits that we might be seeing? On the other hand, you can instead focus less on the whole food and start to break it down to some of the specific nutrients. Is it one or more of its nutrients in the strawberry? Is it the vitamin C or the fiber or something else in the strawberry that might explain its health effects? And that could be expressed either as focusing on nutrients or, in particular, specific supplements with those components in it. And then finally, as I'm trained as an epidemiologist, I always ask the question, is it not the strawberry, but maybe a function of other non-dietary factors, what we call confounding? Could there be other reasons why someone consumes a strawberry that goes away from the direct effect of the strawberry, but maybe it's they exercise more, or they're more health conscious in other ways, shapes, and forms? Now, for myself, as I think about these questions with dietary supplements, both as an epidemiologist and now also as a trialist, I consider the different lines of evidence that we could use to determine the effects of efficacy or effectiveness of dietary supplements. Now, I have this suggestion that the validity goes up as we go up toward clinical trials, but in reality, you have to look at it almost inverting the directionality of this. What we first need is it's important to recognize the importance of the mechanistic studies and the food science that goes into the work that we do in the nutrition space. It's absolutely critical. When we look at the observational studies, so those that are defined as either cohort studies, prospective or retrospective, or case control studies, or cross-sectional studies, these are observational data, but just because they're observational doesn't necessarily make them invalid. We just have to make sure that their methodology is strong enough that they could be valid when we're thinking about whether dietary supplements might improve health outcomes. But inevitably, what we are looking at is looking at the power of things like clinical trials, both short and long-term clinical trials. In theory, if these are done well, clinical trials, because of the power of randomization, gives us much greater insights into the validity of a dietary supplement with regard to either efficacy or effectiveness. Okay, so I've used these terms relatively interchangeably so far, thinking about efficacy and effectiveness, but what are they? How did we define them? And how we define them are actually incredibly important for how we describe the results of a dietary supplement in an intervention or clinical trial setting. And the distinction here is this concept of what we'll call the ideal situation versus the real world situation. And that's how we distinguish efficacy from effectiveness. And we'll look at this in a few different ways over the next few slides. On the most simplistic level, we ask the question of efficacy as, can a dietary supplement work under ideal circumstances? On the other hand, when we think of effectiveness, this has more to do with implementation, real world. Does offering a dietary supplement work under the usual practices when you give someone a dietary supplement and you ask them to take it? Each of these options, efficacy versus effectiveness, have implications in terms of internal versus external validity, or otherwise known as generalizability, as we will see. So let's start with a deeper dive into efficacy trials. This again asks the question, can a treatment such as a dietary supplement help under ideal circumstances? Well, what's ideal? Well, there are specific elements of efficacy trials that are important to consider. First, we assume that the patients that are given the dietary supplement accept that intervention that's offered to them. They're going to say, yes, I will take it. And not only that, but they'll follow the instructions for taking that supplement or supplements faithfully and correctly. In addition, in an efficacy trial, you're assuming that they're getting the same standard optimal care, health care within the system. And there are not other diseases or other outcomes that could get in the way of that care for that testing of the dietary supplement. Now, most clinical trials are, of course, designed this way. And when we analyze trials as efficacy trials, we make a very heavy analytic assumption called intention to treat analyses. The idea behind intention to treat analyses is that once randomized, always analyzed. So if I go into a trial, I'm told to take a vitamin C tablet, I am going to be analyzed as if I am taking that the whole way through, regardless of what I actually do. Now, the advantage of efficacy trials when they're designed and analyzed as intention to treat is that it eliminates confounding. Confounding is the scourge of epidemiology, of observational studies. Confounding makes it difficult for us to really decipher, delineate cause and effect. So the strength of an intention to treat analysis in an efficacy trial is that we can eliminate confounding, and that's the reason why we often do clinical trials in the first place, is to eliminate confounding. Now, just as important as efficacy trials are effectiveness trials. And this asks a separate but equally important question. Does a treatment such as a dietary supplement help under ordinary or real-world circumstances? So what are real-world circumstances? Well, think about it. Usual elements of patient care. Could be differential effects. Some patients get treated for hypertension, others don't. Subjects or patients might not always take their assigned treatment, including a dietary supplement. Just because I'm given a vitamin C supplement doesn't mean I'm going to necessarily take it. Why don't I take a particular supplement? Well, that's an important question too. In addition, I might just simply, or a subject might just drop out of the study entirely. Now, that could be related to the treatment or the dietary supplement that they're taking, or it could be related to other reasons outside of the impact or the influence, if you will, of the dietary supplement. Now, just as important is that subjects might also find ways to take the treatment that they were not assigned. So just because I might have been assigned to take 2,000 international units of vitamin D each day, I might have been figured out that I was assigned placebo, and I might find it terribly important to try and take it anyway, and I go to the store and I take the supplement anyway. And then finally, another element of effectiveness trials is that the doctors in the facilities that are overseeing the patients in the study might not always be the best or the same across the board. Not everyone's in the same healthcare system, per se. Now, in an effectiveness trial, you want to describe the results as most patients would experience them. It's a real-world presentation of results. And because of that, you get away from intention to treat analyses and instead present various forms of compliance-based analyses. Now, while this is a real-world presentation of findings, the problem is that it introduces confounding. And because it introduces confounding, it essentially kind of neutralizes the reasons why we consider randomized clinical trials in the first place, like a coin flip. With confounding being introduced, we have to be very careful not to over-interpret effectiveness trials. So let's look at this again from the perspective of dietary supplements when we're analyzing the data. So again, for intention to treat analyses, which is the hallmark of an efficacy trial, we're measuring the effect of a dietary supplement as assigned to that treatment. It includes all randomized participants in your study, no matter how small or large it is. And it includes all of the follow-up time that you might have up to an incident outcome. So whether you have a 6-week or a 6-year trial, you're counting all of that participation of that participant into your calculations for your intention to treat analyses. And perhaps most notably, your treatment assignment never changes. Again, once randomized, always analyzed. So I might be randomized into a trial where I take vitamin D for 3 years. After 2 weeks, I decide, I don't want anything to do with it. Well, you know what? Regardless of that fact, I am analyzed as if I was randomized to vitamin D the entire time. Now, in contrast, the compliance-based analyses estimate the effect of receiving a treatment, actually receiving the treatment, such as a dietary supplement. Now, 2 examples, there's a few different versions of compliance-based analyses, but 2 common examples are, one, first of all, a per protocol analysis. That's where you only analyze the data from participants who actually follow the protocol as you specified. So all might start with the randomized treatment assignment, but then you exclude any people or data with follow-up time after they become non-compliant. So if I start the study taking vitamin D as I have been told to, but at 3 months in of a long study, I decide to stop taking it or not take enough of it, I'm not compliant enough, my follow-up time stops right there. On the other hand, an as-treated compliance-based analysis looks at the data and analyzes it for participants based on the treatment actually taken without regard to the treatment assignment. So I might start by taking a dietary supplement, stop for a period, start again, stop again. In an as-treated compliance-based analysis, you're going to select all the time that I'm actually taking the treatment. So one of the challenges when you look at these is, which is right? How do you decide? I would actually submit to you there is incredible discrepancies in the scientific field as to which one is right. And different people will give you different answers. And I'm not here to give you the answer either, other than to consider the impact of these different approaches to the analysis. Now, there's something called the implementation gap, and this represents the difference in the effect that you might have when you consider efficacy versus effectiveness analyses. And the reality is that there's a gap, as you can imagine, not just for dietary supplements, between ideal care and typical care. But it's incredibly important to consider this gap, this implementation gap for dietary supplements. And this is especially true relative to other interventions, as you'll see. Now, typically, we like to start with efficacy trials that precede the effectiveness trials. If the supplement doesn't work under the best circumstances, how is that going to work in the suboptimal circumstances for an effectiveness trial? But at the same time, I think one can argue that you want to really consider both types of trials when you're evaluating a dietary supplement, because we need to understand the limitations of the dietary supplement or the trial design or your patient population or the generalizability to understand what that implementation gap consists of. Now, one thing that's, for me, always been very neat about dietary supplements is that they're particularly well suited to evaluate efficacy. Now, not all dietary supplements, but you have typically the ability to have placebo control. You can look at a very simple intervention. It's a dietary supplement versus a placebo, as opposed to more traditional dietary modification trials. Lots of things going on when you're trying to change diet in aggregate or even aspects of the diet through substitution or otherwise. And dietary supplements are particularly conducive to both small and large-scale clinical trials. However, even in the best of circumstances, it's difficult to achieve ideal efficacy. And as you can imagine, the larger or the longer the trial, it becomes even more difficult. And also when you start to consider the impact of side effects. Compliance is never really 100%, it's less. And loss to follow-up is never 0%, it's more. And so there's this slippery slope that exists between efficacy and effectiveness that's incredibly important to disentangle. So with this in mind, I just want to give you an example of the impact of generalizability, just as one example. And this pertains to the Physician's Health Study, which is a large-scale trial that I've been involved in for quite a bit of time. But more importantly, the impact of this is in a way that if you look at the way you recruit for any trial, whether large or small, those who respond, who might be willing, who might be eligible, and who might ultimately be randomized, there will be incredibly important differences with regard to their eligibility status and how that could impact their participation in the trial. So as one example, if you look at the impact of if you respond to a survey or a recruitment mailing, or if you're willing or not willing, particularly if you're willing, or if you're eligible, or if you're randomized, as you see these bars go down, your mortality rate goes down. So one argument I always like to joke is that you want to be in a trial because those who enroll into clinical trials are healthier on average than the general population. So if you want to live longer, enroll in a clinical trial. So the other part of efficacy in particular that gets interesting gets manifested in the most recently published 2022 U.S. Preventive Services Task Force recommendations on dietary supplements. They focus on efficacy as the central tenet for basing their recommendations for dietary supplements, at least with regard to major morbidity, so cardiovascular disease, cancer, and mortality. And all of their questions, everything that they frame around their recommendations is based on efficacy, in essence, intention to treat analyses. Now, I'm not saying that's right or wrong, but it's something to consider, that you have this spectrum, that there is an implementation gap to consider as well. And as you can see in particular, what they state for this grade I or insufficient evidence statement is that there is still insufficient evidence to assess the balance of benefits and harms for the use of at least some of the ones they evaluated, multivitamin supplements, as well as single or paired nutrient supplements for the prevention of cardiovascular disease and cancer. This included vitamin D with or without calcium, folic acid with or without B12, vitamin C, and selenium. And what's interesting is when you look at the studies that they include for the basis of their recommendations, and of course we can really kind of piece these apart. But if we focus, for example, on a multivitamin, they only included one trial, so it's kind of hard to do a meta-analysis here. But even for any cancer, there's only a small number of studies that factor in that they can look at efficacy as intention to treat analyses. And whether you're looking at a multivitamin for which there's some kind of modest, but not except for any cancer for which there's a 7% reduction. It's not strong, but there's at least suggestive evidence for multivitamins being perhaps beneficial, no different for beta carotene being harmful. And if we look even at other outcomes, it's a mixed bag. But more importantly, when you look at the safety and research needs that came out of the U.S. Preventive Services Task Force recommendations, on the safety standpoint, of course, you're limited to those participants that were studied. There's little evidence for harm. Excessive doses might cause adverse effects. But more importantly, these recommendations are confined to the community-dwelling non-pregnant adults, not necessarily those that are children, chronically ill, or nutritionally deficient. But what they emphasize here, which to me is interesting, is that they talk about the need for studies that should be long enough to detect effects on CVD and cancer. Of course, it makes sense, but the longer the study, the further you get away from efficacy because of the challenges of compliance and loss to follow-up. And then also in their recommendations, they emphasize, again, the need for heterogeneity of baseline nutritional status and socioeconomic status. That does make a lot of sense for understanding whether there are particular subgroups that might benefit more or less or not at all from dietary supplement use. But these guidelines don't address many of the things, other health outcomes besides CVD, cancer, and mortality, interactions with other medications and supplements, and overall quality and safety standards. So another question that I get asked all the time is, well, what about observational studies? Can't they somehow demonstrate efficacy in some way? And my response to that is yes, but no. I mean, larger cohort studies or observational studies might have a lot of people or maybe even greater numbers of endpoints, but that alone doesn't, just because a study is bigger, that alone doesn't constitute greater efficacy. Observational studies introduce confounding, and there's always residual confounding that could come into play. And again, we know that people who take dietary supplements tend to be a little different from those who don't. And just to illustrate this, this is data from, again, the Physicians' Health Study. These were male physicians, but even within that relatively narrow segment of the population, we see that those who are using supplements tend to be older, tend to be, for biomass index, it's a bit of a mixed bag. Sometimes people who are leaner tend to be using multivitamins and other supplements. On the other hand, smoking status. So smoking status does come into play a little bit. The current smokers are a little bit more likely to be using a multivitamin. Well, why is that? And then other factors like exercise, current aspirin use, hypercholesterolemia, even fruit and vegetable intake. If you're consuming fruits and vegetables sufficiently high, you're more likely to be using supplements. So from a confounding standpoint, we know that dietary supplement studies are not in a very strong position to address efficacy in particular. And that's why they were not included in the U.S. Preventive Services Task Force guidelines. So another way that sometimes you'll see the argument, at least, that there could be a case for efficacy is that you see lots of meta-analyses, pooled studies that combine a lot of the observational studies. In this case, combining studies that have examined circulating 25-hydroxy-D levels and the risk of cardiovascular disease. Lots of good studies on their own. You combine them together, it suggests that if you have elevated levels of the highest category of 25-hydroxy-D, that would increase the risk of total cardiovascular disease. So this might be true, but the observational data, even when you combine them, are still subjected to the same concerns of confounding, as well as heterogeneity of these different studies that are being combined. So it doesn't necessarily buy you a ticket into that role or to that room of efficacy or even effectiveness per se. So it's always important to look at these data with caution. So I'd like to bring this back, kind of double back to what some of the research that you might be involved in and what a typical dietary supplement trial might consist of. And this is massive generalization. But you might have testing some dietary supplement. You might have about an 8-week treatment period with follow-up. Hopefully it's randomized, double-blind. Perhaps it's placebo-controlled, and you've got placebo control, so that's a huge advantage. You might get several dozen patients that come in, a mix of men and women, hopefully some diversity, with elevated blood pressure. And you're looking to see if you have a supplement that might lower blood pressure. So for your outcomes, you've got changes in blood pressure. You might look at brachial artery stiffness, maybe some biomarkers that might be of particular interest. So a question I guess get asked all the time, is this a trial that can demonstrate either efficacy or effectiveness? So I would say the answer to this question is, again, maybe. Efficacy, probably not. Now, efficacy, we typically align with clinical endpoints, clinical outcomes. And smaller or short-scale trials are almost always going to be in a better position from the perspective of compliance. It's much easier to ask a participant to take something for a few days or a few weeks than it is to take something for a few years. And even if something works over a few weeks, if you stop taking it, you probably assume that there'll be some reversibility in the effect, that you're going to lose whatever those benefits are. So can the small scale trials demonstrate efficacy or effectiveness? Probably not. That being said, though, if you've got good methodology and you've got a mechanism of effect that's clearly stated and delineated through your outcomes that you've defined, you could be in a good position to start to build the case for potential efficacy or effectiveness. The challenge is reproducibility. One good trial denotes another, ideally. But getting the clinical outcomes is really what matters. We've seen many studies of dietary supplements that show promising mechanisms, but whether those mechanisms translate to the clinical outcomes is a big question that's not always been unified. And of course, the impact of generalizability is important as well. And another example, so just as before we looked at a meta-analysis combining results looking at 25-hydroxy-D levels as a marker of vitamin D status and cardiovascular disease, you'll typically see, now each of these lines represent individual, smaller scale, short-term, well-conducted clinical trials that have looked at the impact of magnesium supplementation and changes in systolic blood pressure. So obviously you see a lot of noise here. Some studies it was good, maybe not as good. Overall, there was actually a modest reduction of a few millimeters mercury for those taking a magnesium supplement versus a placebo in lowering systolic blood pressure. Now, as you can imagine, there's differences on the type of formulation, the dose, the amount that was tested, how long follow-up was. This is not accounted for here. But still, does this potentially demonstrate either efficacy, which placebo control, probably high compliance, or perhaps effectiveness? If you took those into account, how does it look? Here you start to make an argument for efficacy. The challenge is whether this is a long-term, durable effect or not. And it's hard to tell just off of a simple summary overall figure here that it is statistically significant. But it's still promising, and in fact actually led to a qualified health claim from the FDA more recently with regard to magnesium and blood pressure. But if you look at that language, there's actually a lot of qualifying language around it that it's not definitive, but yet it is, the evidence is there to suggest that there is a potential benefit. So I want to walk you through two particular large-scale clinical trials that are good examples that I've been involved in that bring up important questions of efficacy versus effectiveness. The first one is the Physicians' Health Study. This was a large, simple, randomized clinical trial that was done by mail, and nearly 14.5 US male physicians aged 50 and up. Now, it tested actually 4 different dietary supplement interventions. I have the example here. I'd usually like to pass these around, but imagine grabbing these. But we send around these as calendar packs, and you'll see why this is particularly important. The Physicians' Health Study, at least with regard to the multivitamin, multimineral intervention, had about 11 years of treatment and follow-up. And we had as primary endpoints both major cardiovascular events and total cancer, with several secondary endpoints. And as you see at the bottom here, our compliance is actually, now we call this high. You can decide that for yourself. At 4 years into the study, compliance with the multivitamin was 77%. It was 72% by 8 years. And by the end of the trial, 11 years in, 2/3 were still taking it. Some people would say that's good. Some people would say it should be higher. Of course it should be higher, but how does that impact things? So if you just look at traditional intention to treat analyses, here's what you find. So the impact of the multivitamin was equivocal on major cardiovascular events. This hazard ratio was 1.01, which means that there was no effect of taking a multivitamin versus placebo on major cardiovascular events. Now, there was some suggestion among secondary outcomes looking at MI death that was borderline but statistically significant. And there was some directionality, if you will, for total mortality, but again, far from statistical significance. But this is under ideal circumstances. We assume that as you are randomized is how we always analyze you. For cancer events, again, intention to treat analyses. Those that were randomized to take a multivitamin had a significant, borderline significant 8% reduction in total cancer compared to those assigned to placebo. And then for some of the site-specific cancers, we saw a similar reduction in risk, although not statistically significant per se. And again, for total mortality, it's the same before. And we also saw evidence that older men might benefit more as well. And for those who had a history of cancer, among about 1,300 who came with a history of cancer, the effects were also stronger. But these were intention to treat analyses. But yet, one trial begets another. From this, the Physicians' Health Study 2 trial was born the Cosmos trial, the more recently completed trial that I was involved in. And this was called the Cocoa Supplement and Multivitamin Outcome Study. So the multivitamin was one strong justification for this trial, as well as a second intervention, a cocoa flavanol supplement or a cocoa extract supplement. So this was about a 3.5-year trial median follow-up, similar primary outcomes for total cardiovascular disease and cancer, and in about 21,500 older men and women. Now, what's interesting about this trial, where I want to bring in this concept of efficacy versus effectiveness, is the notion of compliance. So just as we had for the Physicians' Health Study, grab the other one here, we have the calendar packs that were used in the Physicians' Health Study. And as you can see, the nice part about these calendar packs, now, these become kind of a badge of honor, if you will. These participants were wonderful collaborators, and they would take these with them, whether they were hopefully staying at home or traveling around the world. These were more, these calendar packs are better travel than I'll ever be. But mind you, the calendar pack served as a way to enhance compliance. Now, again, why does compliance matter? Think about the intention to treat versus compliance-based analyses. So what you see here is a summary of, for both the cocoa extract and the multivitamin interventions, in terms of how compliance tracked over time. Now, as you can see, this is a shorter trial, so our compliance rates were largely better than we saw for the PHS2 trial, which lasted for a total of 11 years. However, for the cocoa extract, what you can see is by the time the trial closeout took place, our compliance was about 83, 84%. Now, there's two different ways we can define compliance. This one at the upper half defines compliance based on the first time you indicate that you've missed at least 8 days per month taking those pills from the calendar packs. For the multivitamin, it was actually similarly high too. Now, what's interesting in a trial like Cosmos is that the multivitamin, which was something that was already taken by about 40% of the participants before they enrolled in the trial, and we asked them to stop, many of the participants continued to say, I'd like to take it, I'm not sure what I'm taking, or my doctor told me to take it, or I heard about the ARIDS trial, and I know about its benefits for eye health. I really want to take it. I don't know what I'm taking, I'm randomized, I'm not sure what to do. So when you look at total compliance, it's interesting. For the cocoa extract intervention, there weren't that many people taking cocoa extract supplements. So that way, really, if you factor in the compliance with the pill taking or out of study pills, it still remained quite high. But for the multivitamin, it actually went down quite a bit. Now, why does this matter? Well, let's look at the results. So one thing that I would submit to you to consider with how you approach your research in dietary supplements is not just to consider the intention to treat analyses for efficacy. But let's start with that. So if we look at the multivitamin, first and foremost, we see that we weren't able to necessarily replicate the findings for a potential benefit for the multivitamin for the primary endpoint of invasive cancer in Cosmos. Now, when we looked at other secondary endpoints, we did see an interesting finding regarding a reduction in lung cancer that was statistically significant as a secondary outcome. Interestingly, the effects for all-cause mortality in Cosmos was a 7% reduction. That's actually identical to what we had seen in the physician's health study too. But this is intention to treat. One thing that I would suggest is if this is efficacy, let's see what effectiveness might look like. So if we were to consider these analyses from the perspective of per protocol analyses, in other words, once I or some participant stopped taking the multivitamin or were no longer compliant, we stop follow-up. The first thing that you'll notice, I'm going to toggle slides for a moment, is that you have fewer endpoints when you go from intention to treat analyses where you include everyone, all follow-up, all events that happened, relative to compliance-based analyses such as per protocol. These numbers of events went down because we stopped follow-up. If I stopped taking the multivitamin and I had a cancer outcome after that, it doesn't count because I already stopped taking the multivitamin. And of course, in these analyses, to some extent, you're breaking the strength of randomization. Now, in this case, in Cosmos, the per protocol analyses for the multivitamin intervention were basically the same. And this gives us more reassurance that the findings are fairly robust. What's interesting is when we look at the results for the cocoa flavanol intervention, the cocoa extract intervention of Cosmos. So what I first present to you are the intention to treat analyses, the efficacy-based analyses. And what we see is that for the primary endpoint of total cardiovascular events, that there was a hazard ratio of 0.90. There was a non-statistically significant 10% reduction in total CVD for those taking the cocoa extract versus placebo. Now, mind you, if you look at these charts, the chart here, the figure, everything is leaning left. And in particular, as one example, we see that those taking the cocoa extract supplement actually had a 27% reduction in CVD death compared to placebo that was significant. But what was fascinating is that, and this was true across many of the cardiovascular outcomes for potential benefit, is if you pivot toward, go from intention to treat, I'm going to click here, to the pro protocol analyses. Now, again, we lose some of the events, right? We've broken away from the strength of randomization. However, and so the number of events also go down because we're stopping follow-up if you've become non-compliant. But this gives us a picture of the experience of those who are actually taking the cocoa extract supplement versus placebo. And as a result from these effectiveness-based analyses, we see that suddenly our primary endpoint became statistically significant, a significant 15% reduction in CVD for those taking cocoa extract versus placebo. And all the other outcomes actually strengthened, including more of a traditional MACE outcome of just MI, stroke, CVD death. Now, does this mean that we definitively say that cocoa extract reduces CVD? No, not necessarily, but I think it's important to think about both sets of results in parallel as we interpret the findings, not just from large trials such as this from Cosmos, but thinking about other smaller clinical trials that we will design and conduct for years to come. So the one thing I would like to finish with the final two slides is that Whether you're reporting these large-scale trials of dietary supplements or even the smaller scale ones, it's always hard to declare efficacy, and you should always be inherently conservative in your interpretations, no matter how strong the results are, good or not. And you're actually kind of in a no-win situation, at least from my own experience. If you have results that are favorable, that somehow support a particular dietary supplement, a lot of people will trumpet that this highlights the strengths of the clinical trials, and it supports all the observational epi studies that were done. You tested the right supplement, you removed all the confounding, you had the right endpoints, and you considered the proper analyses. Great. If you get unfavorable results, I'm not sure how to define unfavorable, but let's say it's a null finding, or it's weakly, maybe it could even be introducing risk. I mean, there's public health significance there, even if there's risk, but it still would highlight, a lot of people would say it highlights the weaknesses of trials and epi studies. That you tested a single specific dietary supplement, you had the wrong dose, you had the wrong type of formulation, you had the wrong patient population that you selected, that you might have had the wrong endpoints that you selected. But ultimately, it's important to consider all types of analyses, both addressing efficacy and effectiveness when you're addressing and analyzing clinical trial data of dietary supplements. So looking forward, we know that both the short and the long-term trials of dietary supplements will continue. And it's important to consider how we think about these, both in terms of efficacy and versus effectiveness. But ultimately, it's a function of how we design the trials that can address potential efficacy. If we want something to address efficacy, we have to make sure that the design is sacrosanct, that we select the right supplements, that we consider the right doses and formulations, we have the right populations, and the way that we conduct the trial maximizes compliance as appropriate and also minimizes loss to follow-up. Ideally, when we're doing these types of trials of clinical trials of dietary supplements, think carefully about a more hybrid clinical trial design. They're harder to initiate, but they're critically needed. But yet they're really critical, optimal for determining both efficacy and effectiveness. So think about both the clinical outcome as well as the mechanisms that might underlie it. So whether it's longer term follow-up or more shorter term mechanistic outcomes, whatever you do, these types of trials, and in the dietary supplement space more broadly, requires collaboration across many sectors. It's government, it's the Office of Dietary Supplements, it's NIH, it's industry, it's academic positions. It's all of it, when we work together, makes for better science. So with that, I thank you for your attention, and I would be happy to take any questions, and feel free to contact me as well. You have my email addresses. Either of them work, are good for me. And I'm not a heavy Twitter user, but certainly follow what I'm doing in the dietary supplement world through my Twitter feed as well. So thank you for your attention. I'll be happy to take any questions remotely or otherwise.
Okay, thank you, Dr. Sesso. Dr. Sesso, as he mentioned, is not here with us to join us for the question and answer period, but he's happy to accept any questions remotely. So if you remember to add your questions to the Q&A bar, we can share them at a later date. So as we move on to our next speaker, I do want to reemphasize again, please add your questions not to the chat box, but to the Q&A box so that our speakers can have an opportunity to address those questions. So our final speaker for this session is Dr. Mary Hardy. Dr. Hardy is board certified in internal medicine, and she is a specialist in botanical and integrative medicine. Dr. Hardy has actively combined complementary and alternative therapies with traditional Western medicine for over 25 years in both her clinical practice and research projects. For today's presentation, Dr. Hardy will speak on the concept of safety, its measurement, and reporting.
Hi, everybody. I am very happy to be here, and I am especially delighted that we seem to have speakers and participants, especially from all over the world. So I'm going to start talking about safety and the context of it, how you measure it, how you think about it, and then how we would report or should report adverse events that we observe both in clinical trials and in practice. So since I trained as a physician, primum non nocere, or first do no harm, is the basis of most medical practice. And I think it should be strongly our view as we start to look towards studying dietary supplements. We want the information we need. We don't want to do any harm while we're studying, and we certainly want to have the information so that we can make appropriate assessments about safety. Now, I think it's also interesting to think about this. You know, is this an absolute value, or is there some benefit, a balancing act? What do you balance safety against? And this is the first, and I think the most critical assessment for safety. You're balancing risk and benefit, and you're balancing how big the risk is, how serious, how likely, et cetera, versus the same kind of parameters for benefit. How big is the benefit? How likely is the benefit? For public health assessment, regulators think about this on a population basis, but again, I practice as a clinician, so I'm also particularly interested in the issues of how they impact on an individual patient. And this, I think, may often be the difference between efficacy and effectiveness, as Dr. Sesso was saying, but it comes at the level of patient choice, at the individual choice. And that's an important consideration to take into account, that an individual may make the risk benefit assessment differently than a researcher or a regulator or a provider would make. I think this risk benefit teeters on how strongly we can associate the risk with the negative outcome, so the causality. And if that's a tight association, then the risk becomes validated, and then it has to really be put up against a fairly significant benefit. The best example of this, for example, is chemotherapy, high risk intervention, but potentially for a high risk benefit. Now, the other balancing act that I think is really critical as well is this following one, that there's a lot of interactions that affect safety that are based on the patient or the consumer issues, the individual consumer, and there's a lot of issues that focus on product quality that affect safety. So typically, product quality is not necessarily a discussion that shows up in most safety discussions, but I think if we're looking at the level of the individual patient or consumer, it absolutely has to be mentioned as well. So let's see. All right, so relevant patient issues. People are by nature heterogeneous. They just are, and they come in different sizes and shapes and ages. They have different conditions, some of which are medical in an illness sense, and some of which are natural stage of life, things like pregnancy, etc. Within a different day, we all have different status versus our hydration, or how much we've rested. That can affect negative outcomes, especially hydration. Are we physically in a maximal exertion state or not? And then, of course, what other medications, supplements, etc., are being taken. These are conditions that will definitely affect the safety profile that's seen. And sometimes these patient issues, I think, can either outweigh or exacerbate, or at the very least are relevant to the consideration of an adverse event, whether it will occur at all and how serious it will be. This is one of my mentors and a person who's known well to all of us, a pharmacognosist and a head of one of the botanical safety centers, one of the botanical research centers funded by the Office of Dietary Supplement, Norman Farnsworth. And I'm always reminded of his quote, which is, if what's on the label of an herbal medicine, you could say dietary supplement, is what's in the container, toxicity is rarely encountered. Speaking both to this issue of quality, as I spoke to you about a minute ago, but also that inherently well-prepared substances in the continuum of risk or toxicity should be on the lower end. Now, what kind of quality issues might we see, or what things can we see in how a dietary supplement is prepared? I think this breaks down broadly into two areas: intentional and unintentional. There are things that can happen as misadventures. One herb can be substituted for another herb. Things can be mislabeled so that you don't think something's there when it's there. There can be a misidentification of a plant. Your substitution can be for economic reasons, that you substitute one plant for another because this other plant is cheaper. Now, it's not an equivalent substitution, but this absolutely happens. One thing that's unintentional or is in the nature of the material itself is that there can be toxic constituents. Herbs do have toxic constituents. And as Paracelsus said, the difference between a medicine and a poison is often dose. So an overexposure to toxic constituents can have an adverse event. Drugs can be added intentionally and often are to improve the efficacy or perceived efficacy of a formula, very commonly seen, unfortunately, and particularly in categories like weight loss, performance enhancement for exercise, and or performance enhancement for sexual function. And then there have been times when a dietary supplement would be improperly formulated and there will be excessive amounts of otherwise safe ingredients. The modern phytomedicine quality assessment, this is regulated by the FDA. There's multiple steps. I've listed them out for you here. Each one of these is the responsibility of the person who handles the material and then passes it on to the next level. Each level in this should be doing their own assessment of quality, trust but verify. Now, some variability is to be expected, especially in herbal products. These are living organisms that grow under different conditions, light, nutrient, access to water, etc., elevation. Any of these things will affect the nature and the amount of the phytoconstituents inside the plant, because the plant makes these not so that we can treat our mood, but so that we can so that it can protect itself from predators, from UV light, or to do its own metabolic processing. So some of this variability is to be expected. Large companies with highly standardized extracts often combine different supplements, different plants from different places to sort of balance out or keep their final formulation very steady. Variability can be very confusing. It can be a real bane to a researcher, which is why with Dr. Betz, I think it's very critical that what you're testing is highly specific and highly well described. And variability that can be accessed and can be accounted for can usually be taken into account and can be made something that doesn't completely mess up your patient or your trial. But if you have unexpected variability, that's often the result of adulteration. Now, contamination. Certainly we can see in certain ethnic products that there can be inclusion of heavy metals, drugs, etc. Again, a plant will often grow in soil that's contaminated and may sequester adverse elements that we don't want to see in that plant as a process of where and how it's grown. Misidentification, this happens. Here's a famous, now an old example, but it's a pretty nice one. Plantain, which is this plant on the right, has leaves that are ribbed vertically, and this is the inflorescence, not what we call a showy flower, for example. But if you were collecting this in the wild and you were looking for plantain and you had a species of foxglove available and you didn't have this flower, this inflorescence to separate out these two plants, this is an example of when a species of foxglove was collected instead of plantain. Plantain is a very benign plant. So people were getting cardiac glycosides when they weren't expecting to get them. This is a misidentification problem. This is another example of a series of adverse events, serious liver toxicity was seen with black cohosh. And these are adverse events that were reported to the Natural Health Product Directorate of Canada. And And both Dr. Betz and I were involved with this, with the oversight regulatory body as on the scientific advisory panel. And these adverse events were described, and a suggestion was made that there should be a label put on black cohosh could cause liver disease, liver toxicity. A lot of the people who were involved in this said, well, you know, Semisafuga racemosa, Actea racemosa now doesn't really have those, it's not described phytochemically to have toxic constituents in it. So we encourage the director to look more carefully into this. And in fact, it was found out this is another kind of adulteration, which I alluded to before, economic adulteration. And Semisafuga fetida, a Chinese variety, a Chinese genus, not the same genus and species, the binomial name would have told you that, but this was undisclosed economic adulteration, which that herb did have hepatotoxic components. This is an example of economic adulteration because the Semisafuga fetida was cheaper than Semisafuga racemosa. If you are a consumer looking for some kind of guarantee or some kind of help in searching the huge number of products that's available, to have an idea that the quality, that what's in the bottle is what's on the label as per Dr. Farnsworth, then these are examples of seals or stickers that you might look for. These are general ones, and these are specifically for sports. Our athletes would look there. Now, how can you find out about safety? If you want to make an assessment, a safety assessment, how do you do that? Where do you go for information? And sources of information are highly variable, and they can range from traditional knowledge, and we've already heard a little bit from Dr. Betz about the limitations of traditional knowledge. It's only valid if you're using the material as it was used traditionally, which we often aren't, and if you're using it for the indication for which it was used traditionally. So, for example, in traditional cultures, which are low technology, they may have a lot of observable empiric data about the utility and safety of something for acute care and acute short-term toxicities. So they might know a lot about pain, and they might know a lot about if any intervention caused an immediate problem. However, I don't think they're going to be, traditional knowledge is not going to necessarily guide us as effectively for conditions which are not known in that culture. So like atherosclerotic vascular disease, for example. But I think you have to also remember that there is a place for this, but you have to use it appropriately. You can look for pharmacologic mechanism of action studies. These can begin, as Dr. Sesso said, in vitro and animal studies that can give us an indication, but really for pharmacologic data about safety to be really reliable, it should be done in humans. There have been many times when in vitro work does not, and even animal work doesn't translate into the same effect in humans. So really hold pharmacologic data lightly unless it's human data. A much more sophisticated way that is being used now is looking at in silico, doing computer modeling to say, if we know that this particular compound has XYZ toxicities, then if we can take this compound and compare its structure, 3D structure, can we make any assessment, or can we have anything to say about its toxicity or its likelihood for toxicity based on an in silico consultation? Maybe, again, it's an indirect measure, but it's a powerful one nonetheless. The phytochemistry or the chemistry of the compound is very important because there are toxic constituents. We want to know about that. Observational data has its place. It starts to raise the bar to start to think about safety. Especially observational studies may be quite large. They might tell you something about safety. Pharmacovigilance studies are often done after a product is labeled and or licensed and or being sold. There's voluntary pharmacovigilance that might be performed by the company, and there's mandated pharmacovigilance. You'll see a lot of pharmacovigilance studies from Europe because those had been required that after a product was sold, there would be a period of time in which pharmacovigilance would be instituted to make sure that there were no untoward or unexpected adverse events that were happening. Where we get a lot of information and a lot of literature shows up, and a lot of, unfortunately, since potentially sensationalistic reports in the lay literature, are adverse event reports. These may often be dramatic, serious events. Usually they're rare, hopefully they're rare, but those are an important source, and we need to look for clusters. We need to look for any indication about what kind of patient or what kind of substance might be the most likely to cause an adverse event. Now you'd say, well, we randomize people in clinical trials. Why can't we just use the adverse event reporting? Let's make sure it's included in all clinical trials. I'm absolutely for that. But let's also make sure that all controlled trials report adverse events. And if our blinding, if our randomization has been successful, then that should tell us something about adverse events. And that's true, but it's only going to be good for random events which are common, and I'll explain that in a bit further. So as I've just briefly alluded to, all sources of information have strengths and limitations, and often takes a global assessment of multiple sources and multiple lines of information to be able to give a full, complete safety analysis. Traditional use, I think I've pretty much told you about this. The most relevant precedent here was the German Commissioning Monographs, and the Canadian Natural Health Product Research Directory also made room for traditional use of products. And the assessment was that since these are often used in forms like teas or tinctures, not in highly standardized or highly concentrated forms, that made their safety more acceptable and therefore could be put into regulatory frameworks. Now, let's look more closely at the adverse events. The adverse event reports generate attention. This is from the FDA. There can also, I can have sort of showed you things from lay literature going from the LA Times all the way up through Time Magazine, etc. But I want to speak more about the adverse events because this is where we usually get a chunk of data that we want to look at. And unfortunately, adverse events and adverse event reporting are complex, multifactorial, and assessing causality may be quite challenging. So any of these mechanisms here could be the cause of an adverse event. You could have gotten a poorly manufactured supplement. There could be inherent toxicity in the material. There could be inherent toxicity for a particular group, a particular patient group, as I spoke to about consumer issues. There could be pharmacological effects that could augment or exacerbate something that the patient is already taking, a drug, for example. There could be misuse. Patients often, it's unfortunate but true that patients don't always do what they've been instructed to do, either by a provider or by the label of a dietary supplement. And many people have a strong belief that if one is good, four is better, so that they may take too much of a dietary supplement or take it in circumstances other than for which it was intended. And the final analysis, things happen. People have idiosyncratic reactions. They could have an allergic reaction. And those can be a mechanism for an adverse event. Now, this is from a manuscript that was unpublished that I read when I was working at the RAND Corporation, and we were looking at ephedra in particular. We were really interested to see how easy is it to find information about adverse events in PubMed. The mesh terms are not very sensitive. So if you just say adverse or adverse events or adverse effects, you start to get more of these reports start to pile up. But as a side effect that you know and can expect, is that the same thing as an adverse event? Side effects imply mild, reversible, probably not going to be a major issue, may or may not be severe enough to cause someone to stop taking a supplement. Adverse events generally imply something more serious. So as you can see here, any one of these terms could be considered useful or appropriate or a mesh term. But since you're going to have to cast your net a bit broadly, if you want to find all the reports, you're going to need probably multiple terms, and you're likely going to have things you're sifting out that are not germane to your analysis of adverse events. The definition of a serious adverse event is conventionally meant something that's very serious, that causes death or a life-threatening medical event, or that requires an evaluation, assessment, or treatment, either in an emergency room or in a hospital. If it's persistent, if it causes congenital abnormality, or et cetera. So from the conventional sense, we think it has to be an important medical event. In reality, it's pretty much anything that the patient deems is serious enough to report should be considered serious enough for reporting to the FDA MedWatch. Now, what complicates this? When we get an adverse event report, we have a lot of uncertainty. There's always missing information, and sometimes it's critical information, and sometimes it's information we would just like to have. You know, the composition of the product makes a difference. Only half of dietary supplements sold are sold as a single agent or a single ingredient in that supplement. However, when we attribute risk, we often attribute risk to one component of a formula without necessarily having a mechanism to take all of the other complexity of the other constituents in this formula into account. So is the potentially offending agent the actual cause? Is it the only cause? Is the action of that potentially offending agent made worse by the material that's the other material in the formula, etc.? You get my idea here. And again, patients, products, etc., conditions of use are all variable and may or may not be specified. So for example, the patient population is generally specified. Do they have medical conditions, etc.? The composition of the product should be critical. And whenever possible, the actual offending material should be analyzed to accompany, the analysis should accompany an adverse event report, especially in the medical literature. And the conditions of use are rarely reported and sometimes can be absolutely critical. And you'll see that in the ephedra analysis I'm going to show you a bit later. Okay, so again, this is my pitch that those of you who are doing research absolutely collect safety data. Collect it in the usual routine way where you do routine lab work. Then you also should query the patients about both expected and unexpected adverse events. You should query them in an open-ended fashion. Did anything happen that you didn't expect or weren't comfortable with? But you also could then follow that with specific targeted questions about adverse events you expect to see. Did you have a headache? Did you have nausea? Did you have vomiting? So that you can more fully elicit any adverse effects that the patient might have seen. As Dr. Sesso told us, running clinical trials is expensive and complicated, and we should really, really optimize the information we get out of that kind of a setting. And so be sure to collect this data and be sure to describe the material fully that you're testing in a clinical trial, absolutely, and that you also are going to report on in an adverse event report. Now, when you're talking about making an assessment, you're talking about, can you connect this material that was taken to the adverse event that was observed? Is there an appropriate connection? Does the pharmacology match up? If I take ephedra on Tuesday of this week and don't report an adverse event until 2 months later, and there's been no intervening use of that material, well, that is not a very tight association and likely would not be data that would be demonstrating a causality event. So what you know about the toxicology of the material, what you know about the pharmacology, what is PK maxes, after a dose, how long does a dose last? For repeated dosing, do toxic metabolites build up, etc. So the pharmacology is really important. Exposure is critical, and you have to document exposure. So it can't just be that someone said that someone took. Hopefully you'll be able to say, this person took this, I saw the bottle, I can document that they took it, and this event happened. I've observed the event. Those two things are tightly aligned in a way that could predict causality. And that is the main event. Now, the one thing that's particularly difficult about causality assessments is you have to rule out alternate explanations for the adverse event. And that usually requires clinical experience and can be tricky. Okay, so our randomized controlled trials can attribute causality. Anything that's observed in one group and not observed in the other could be thought to be associated with the intervention if randomization was successful. Again, the problem is this is only going to show you side effect common type of adverse events, because for randomized controlled trial to demonstrate a serious adverse event, which God willing are much less likely than average, much less likely, they're considered very uncommon or rare events, you would have to enroll 3 times the number of participants for the predicted prevalence. So if I think something happens 1 in 1,000 times, which is not so rare, I'd probably have to have about 3,000 subjects to be able to comfortably say that that rare adverse event, if it wasn't reported because it didn't happen. I had enough opportunity to observe it, and if I didn't see it, it didn't happen. Cohorts might be able to attribute causality. They are somewhat controlled, and it's going to depend on how well you are able to match your cohort to the non-users versus the users. Case reports, I don't think, can really definitively demonstrate causality. The strongest evidence is a de-challenge, re-challenge. So for example, I get an adverse event because I've taken something that's not a terminal event like death, but something less severe, let's say. So I stop taking my supplement, that event goes away. So I had migraines, they now stop. And I figure, well, it could be the dietary supplement, but I really want to keep using it. So I started up again, that's a re-challenge, and I observed the adverse event a second time. De-challenge and re-challenge. That's the strongest kind of case report. And I've only seen it very, very rarely in the literature. Because again, for some serious adverse event, you do not want to re-challenge someone who's had a stroke, a heart attack, suicidal depression, etc. It's unethical and it's not advised. There are lots of other kinds of studies that can be done, drug monitoring, case controls, reports to poison centers, etc., can give us a signal that that there's a potential problem here on a public health level, but causality cannot be directly attributed. Now, public health action can be taken even when causality is not completely definitively demonstrated. Okay, so this is what I told you before. This is a limitation of causality in clinical studies. Also, in general, people tend to underreport adverse events, which is why you have to ask for them specifically. And very few studies are run as safety studies, but there are some, and I'll show you a bit later. So even adverse event reporting, there's significant underreporting. Follow-up is rarely done. The report is only as good as what the reporter tells you. The offending material is rarely seen, but this may be the only way to discover rare but serious adverse events. This, I think, is the trickiest piece in adverse event causality, limitation of other causal factors. It requires a lot of information, and it requires a largely clinical decision. I was involved in doing the ephedra analysis at RAND, and I read 1,400 adverse event reports, and for every serious adverse event, luckily the FDA had collected a lot of data, and in analyzing some of these adverse events, I had full hospital charts, which might have been multiple pages. So in that case, I think I had the data I needed to make as good an assessment as could have been made, but that was an extraordinary level of data, which is generally not present in adverse event reports. So if you become a reporter, remember, the information is only as good as what you report, and at the time of the adverse event, when you discover it, is when the information is the most intact. So please tell us everything you know. Okay, safety studies. These do happen, and they are great. So this is an example from the study that Paul Schickel and I did with Sally Morton and the rest of our group at RAND. And it was looking at ephedra adverse events. And this was prompted by a flurry of reports, and especially a great deal of uproar in the lay literature, lay public, like magazines and newspapers and stuff, because a few high profile folks had a serious adverse event and were later found or are thought to have been taking ephedra. So we did this analysis. We took every randomized controlled trial that was appropriate, looking at ephedra for weight loss and athletic performance enhancement. And we found a number of studies, and then we subsequently, this is looked at these studies and did an analysis for looking at the adverse events as reported in the study. Okay, and we categorize them in these following categories. The ones in pink are ones that were statistically significant. Sometimes these symptoms didn't make sense, that one would be significant and one would not. So our heart palpitations, the same thing as tachycardia. You know, often patients perceive tachycardia as a palpitation, and so one was statistically significant and one was not. So I do show you this data so that you can see that for common events, which you might observe, if you took enough of this material and you took it consistently enough, you could reasonably expect to see irritability, autonomic hyperactivity, startle, and trouble sleeping, heart palpitations. And a very common adverse event for dietary supplements, one of the first adverse events is often GI symptoms, nausea, vomiting, upset stomach. So you can see for these common events, we could, with a fair degree of certainty, because if randomization was successful, we can say by pooling all these different studies, we could add up enough numbers to start to say whether something was, or the odds were likely or not. So you would be, you know, almost 4 times more likely to have some kind of psychiatric symptoms, a little bit over twice as likely to have a GI symptom, for example. Now, but that doesn't tell us really about the things that most people were all upset about, was death, stroke, it's suicide, etc. So this is looking at a different analysis where we took the adverse events reported with the consumption of ephedrine. And this also, I'm just going to back for 1 second. We didn't just look at ephedrine, we also looked at ephedra. I didn't show you those slides here, but I'm going to show you here for the adverse events. So we wanted to compare the herb to the major constituent, which is sold as an over-the-counter drug. And so we're able to sort of balance these off against each other and see, was the herb more or less likely to be reported than the over-the-counter dietary supplement. And I'm just going to show you, for example, that they look very roughly similar. Ephedrine look very roughly similar. There may have been some, like in cerebral vascular accidents, there may have been more reported in the ephedra. Seizure may be more reported in the ephedra, but for some other adverse events, they're roughly the same. Now, if we're trying to say that we think something is very likely due to the material that's been identified as the potential causal agent of problems, in this case ephedra, so we called it sentinel events. And then if there were a lot of other explanations, medical, clinical explanations for why someone might have had a stroke. Okay, yes, they took ephedra, but they had high blood pressure. Yes, they took ephedra, but they were smokers, etc. Then that was a possible sentinel event, that there was, the ephedra was present and that adverse event was present. It could have contributed, but it wasn't clean. It wasn't, the events were clouded by other potential causes. Now you can see that we had probably about half or a third, maybe up to half of our sentinel events occurred in this younger age group, 13 to 30-year-olds. And that's not a surprise, because this group often had doesn't have a whole lot of other medical complaints. They're not hypertensive, diabetics, etc. However, one thing that happened in the that I think was potentially causal here was that they had behavioral activities that may have contributed to the adverse event that was observed. I'll give you an example. There was a young man who was a wrestler, wanted to make his weight class. So he stopped eating, dehydrated, put on a rubber suit, went into the steam room and rode a bicycle, rode an exercise bike, and then had probably a heat stroke or a heat-related adverse event. And ephedra was present, but so were all these other conditions as well. So this was, remember, this is only going to tell you things that might be causal. And if you start to pile up enough of them, then a public health decision as could be made, as was made, related to ephedra to limit sale, except for traditional Chinese medicine usages, where the quality and the manner of the use was completely different. And none of our adverse event reports involved a Chinese formula containing ephedra. Okay, here's just an example of a second safety study, which I call to your attention because it's such a good study in a lot of ways. It's a long study, it's open label, but it's an observational study in that way. But it went for 12 months. It took postmenopausal women, black cohosh was being used to treat their symptomatic menopause. This was a standardized German extract. There's the dose. And they did an effect size calculation because there was a discussion at this time. Is black cohosh an estrogenic material or not? There was mistakes, I think, that now in retrospect were pretty clear, were mistakes in the literature that attributed estrogenic activity to black cohosh, again, without phytochemically having that look likely. So this was going to be a definitive safety study to start to look at the estrogenic effects, potentially, if they were present, of black cohosh. Now, remember, if I'm going to depend on the absence of a symptom to tell me that something's safe, I need to be sure my study is big enough that if it was there, I would be seeing it. So they did the effect size calculation based on estrogenic effects, and they looked at endometrial thickness, which is an estrogenic effect. They also looked at maturation of vaginal smears as well, looking at the epithelial cells there. And so this was a very good set. They did uterine ultrasounds as well as biopsies if necessary, vaginal smears, etc. They looked at the usual kinds of blood studies, and they recorded adverse events as reported. So this just shows that on a scale of estrogen maturation, this is at visit 1, this is at visit 7 at a year. There were very few adverse events, like this was one outlier, but that patients in general went to the less matured epithelium, therefore showed less estrogen effect. And this is looking at biopsies, the same thing. This is looking at chemistries, and it showed here that there were no increases in the sex hormones, that lipids did show a statistically significant increase, but the increase was small. It was 13 points, and likely that was not going to be clinically significant. Liver function studies, there were some statistically significant liver function studies, and the number could be significant. However, I actually requested and received the individual patient data for this trial, and I did not see liver elevations which were consistent from week 1. They did interim measurements. I think they did 3 interim measurements. And so from measurement 1 to measurement 2 to number 3, measurement 1 to number 3, there was no evidence of a sustained elevation, and the level of elevation could be consistent with having had a night out drinking, for example. So I don't think this signal is definitely connotes the presence of adverse liver function tests and liver damage and liver toxicity, going back to the fact that adverse event reports with black cohosh claiming liver toxicity had been made, but this study was one of the pieces of evidence cited to say, that doesn't sound like black cohosh as we know it. Mandated reporting. It's new. It's a relatively new rule from 2007 made by the FDA. Dietary supplement manufacturers are required to report mandating reporting. And this is, and they can then, they're required to report all serious adverse events, everybody at all stages along the route. Whoever gets the call from the consumer has to do the report. I did a data analysis with APA and with Merle Zimmerman, who's I think on the call. You're going to hear from him later. We looked at the first 2 years of adverse event reporting after the 2007 rule went into effect. We saw one cluster of serious adverse events, which then was a compound, athletic performance compound, which was then taken off the market. The rest of the studies, the rest of the adverse event reports were actually not particularly significant, and the the largest number of adverse events reported were from difficulty swallowing the pills because they were too large. And I can absolutely attest to that from personal experience as well. So a signal is a sentinel event. When you have a cluster, you then look to decide what you're going to do about this. We can talk about this more, but I think that's the basics that you need to know there. You do an analysis. Again, it's like looking at a cluster of adverse event reports, but now you might actually take a public health action. So you should be even more rigorous in your analysis. This is, if you yourself see an adverse event, this is the safety portal from the FDA. There's the URL down below, and it'll tell you, it'll guide you through, it'll walk you through making a safety report or an adverse event report. These are 3 examples of good sources for safety information. The Office of Dietary Supplements fact sheets are monographs on a large number of dietary supplements, each of which includes a safety or adverse event section. The Botanical Safety Handbook, available online from APA, I think is probably one of the most robust and significant sources for looking for safety for herbs. And the FDA then, this is where it tells you, walks you through how to report an adverse event. Thank you. And I hope I have time for questions, but I may or may not. I'm going to stop sharing so that I can answer questions.
Thank you, Dr. Hardy. It looks like you do have at least time for at least one question. But I do want to invite participants to hang on during the break from 1:15 to 1:30, because we may have an opportunity, if Dr. Betz is still on board, we may have an opportunity to address some of the questions to Dr. Betz. So Dr. Hardy, again, thank you for your presentation. You do have a question. What do you recommend for safety assurance of new dietary supplements, those that are introduced to market after 1994, that are related to adverse events not evident in most clinical trials or by epidemiology? And so they're given an example here. Let's see, I'm losing it. So for example, cancer may require 15 years to develop, or there could be a delayed neurotoxicity, genetic reproductive effects, et cetera, and then and so on. So how do you want to address that question?
That's a great question, and I'll give you an example that actually speaks directly to that. There was a weight loss formula that was manufactured and sold in Belgium. It had a number of Chinese herbs in it, and there was an unfortunate substitution of a benign Chinese herb, a Stephania, for Aristolochia. Aristolochia is an herb that has toxic constituents, and they're toxic to the renal system in particular. And again, this is patients, again, who are probably not hydrating well, limiting their intake, which may have allowed the urine to concentrate and potentially could have exacerbated the adverse events that were observed. In the short term, direct renal toxicity was observed, including renal failure, including some people who needed transplantation. That's, again, acute adverse events. The problem was that there was also a delayed adverse event when there was an increased incidence of urogenerated tumors following exposure to the Aristolochia. This substitution would have been allowed in traditional medicine, but was not what was specified in the formula. So yes, that can happen. The best you can do, I think, is to go back to constructing your formula well. Really, and for a new dietary ingredient, there is an assessment process that should, and Dr. Betz or Dr. Kuszak can speak to that from the Office of Dietary Supplement. I don't know if we have anybody from FDA here, but there is a process that's supposed to vet dietary ingredients so that new dietary ingredients, they don't present an unknown toxicity. Unfortunately, rare adverse events are going to happen, and they may not be predictable. And so the best you can do is have a robust pharmacovigilance, post-marketing pharmacovigilance system, which unfortunately we don't, because it's largely voluntary.
Great, thank you, Dr. Hardy. There is one more question in the chat for you, and I think you've addressed it already, but maybe you want to elaborate. It says, do you agree that one way to evaluate an adverse event on an individual level is to challenge, de-challenge, re-challenge method? And I think you spoke directly to that already, correct?
Right.
Okay.
I think that's intellectually always interesting. And as long as you're not re-challenging somebody who had a serious adverse event, is potentially permissible, especially if ethically, especially if you and the patient or the consumer the consumer themselves feels that there's value to be had in this material. So yes, there are ethical ways you could de-challenge and re-challenge, but it should not be done if a serious adverse event has been observed.
Great. Thank you, Dr. Hardy. I'd like to invite Dr. Joe Betz back if he's still on board and maybe able to answer any questions. If not, oh, there he is. There he is.
I'm here.
How are you?
Hi, Joe.
I'm fine. I'm still here.
Great. So we have lots of questions here for you, Joe. I'm just going to go through here and try to pick one to start off with. Do you think that the botanical drug pathway is underutilized or underappreciated in the industry? Let's start there.
The answer is probably yes. It's underutilized, and it probably mainly financial reasons. Botanicals are complicated. And when trying to accumulate the evidence for what constituents are necessary for consistent reproducible biological activity of a botanical is hard to nail down. You've got that complicated chemical fingerprint, which only captures a couple of dozen compounds. There's thousands of compounds in a plant, which means that trying to characterize a chemistry versus biological activity is hard and expensive. And a supplement company doesn't have to make that kind of investment. The law allows them to not make that kind of investment going forward. There are pros and cons to becoming a drug. If you're a drug, you can say what you actually are supposed to use it for, versus, kind of some, mealy-mouthed, generic claim like maintains a healthy immune system. So there's pros and cons. Drugs are reimbursable from insurance plans. Most supplements aren't. The short answer is yes, it's underutilized. The longer answer is it's underutilized for a reason. You have to make a very strong business case to spend that money. The underutilized pathway, as far as I'm concerned, is foreign marketing data. There are some OTC products that are herbs that are marketed in other countries. What you need to get FDA to approve some of these other marketed products is data on efficacy and safety that was accumulated for material time and material extent. So FDA has its own definition. I won't talk about that. So using foreign marketing data to get products that are already in the market in other countries, approved products that are already in the market in other countries, I think would possibly be an easier route to market than the botanical drug route. Now, the innovation is lacking because somebody's already done the work, somebody's already introduced the product, somebody's already done the research. But if you're just trying to bring a European herb, for instance, to market that's already a drug in Europe, and be able to make the same claims that they can make in Europe, then I think that's an underutilized pathway, especially for OTC drugs rather than prescription drugs. So that's a long answer to a short question.
Great. Thank you, Dr. Betz. Here's another one. So regarding randomized clinical trials for dietary supplements, the number of subjects are much lower, particularly supplements for exercise where total subject numbers can be 20 to 30 subjects, or studies looking at EEG and nootropics are even lower. Any idea whether these studies with low subject numbers would be considered as valid substantiation in the event of a substantiation audit?
Again, it depends. I think that's a case by case. It's going to depend on and somebody actually already addressed this in the Q&A. It depends on the effect size. It depends on the statistics. So if you get a very strong statistically significant outcome, it's possible that that's due to efficacy of the product, even if it's a small population size. So again, it's going to be case to case. You're going to have to, do all your all your pre-study calculations to make sure that you've got an accurate assessment of effect size, as well as determine what statistics you're going to use. So sometimes the answer is sometimes yes, it's okay, sometimes no. What I've seen over the years is people who do small studies and don't do a between groups comparison. So you'll have something that looks different than the baseline effect for placebo versus the active intervention. And if you just look at the raw data, it looks like the intervention group looks better. They got better, apparently, from the endpoint. But if you don't do that statistical comparison of the between groups comparison, then the study is basically worthless. So I've actually seen studies like that in posters and abstracts, even in the peer-reviewed literature, where they don't do a between groups comparison. So that becomes the statistical test that one should use. If you've got a placebo, you might as well compare the placebo effect with the intervention effect. So the answer is maybe. Another long answer.
Can I just ask you a question? I think what you may have been getting at was if there's a between group comparison before the intervention happens and that the two groups are balanced, right? Is that what you're saying too?
No, actually I've seen completed studies where you have two sets of data, one that shows whatever the endpoint is at baseline versus the endpoint at completion of the study, and for both the placebo group and the intervention group, without making a comparison between.
Right. I thought we were talking about a within group comparison versus a between group comparison.
Correct.
So you have a before after result for the placebo group and a before after group for the intervention, but you just report that the
within group. Yeah, you just report the within group.
And technically to get rid of the confounding from placebo or whatever, you have to make a between group comparison, and that's the critical piece of data. Also, I think you should make sure that your groups are equivalent before you begin, and an imbalanced group it really voids the whole trial in a lot of ways.
Yeah, I've given other talks about ginkgo of all things. Imagine that, where if you look at the randomization data before the study and after the study, the groups were different, at randomization. So they weren't equal. The measures were not equal at randomization, which is going to skew the end results. If they're not the same at the beginning of the study,
then you've really aborted the whole reason why you do a trial.
Yeah, exactly. Yeah, that was a ginkgo for ischemic stroke study.
Again, a rare adverse event.
No, exactly.
People. You need a lot.
No, this was ginkgo to treat the aftermath. To improve circulation following an
ischemic stroke. That's such a complex clinical situation.
Yeah, exactly. So anyway,
Okay. All right, Dr. Betz, we have one last question, but it's a packed question. It's like 3 questions in one. So I think we're going to make this the last one. All right, here we go. How does the various offices of the government reconcile sponsoring research regarding dietary supplements regarding disease or condition modification? And yet, if the results show positive impacts, companies who make the same ingredient cannot discuss such a use with the public. Is this a conundrum that can be overcome? Will the ODS or NIH skip sponsoring disease condition intervention with dietary ingredients if dietary ingredients cannot be marketed for such? Or will this type of legislation need to be modernized to recognize advancements in the science and public health and nutrition choices, etc.?
Okay, I'll answer the first part, or the last part first. Okay. And that's not about modernization, but it's about Office of Dietary Supplements and what we fund. For the most part, treatment studies have 10-foot pole marks all over them as far as the Office of Dietary Supplements. By law, dietary supplements are not allowed to cure, treat, mitigate a disease in man or animals. So ODS steers clear of those. We fund some risk reduction. We have funded some studies in say diseased animals, where you're trying to get to an underlying mechanism of health maintenance and prevention. So if looking at a disease population allows you to extrapolate backwards in time and effect, then those studies have been, some of those studies have been funded by ODS. For the most part, no, we just stayed away from those. Now I've been gone from there for 5 months now. So what's happening now, I really can't comment on. But that was kind of the modus operandi from when the office was founded up until I left, was not going to fund a study for treatment of a disease for the most part. In terms of reconciling the studies, some of this is technical or legal, and we could ask FDA and FTC to clarify, but I think part of the answer is part of the talk that I gave. I showed you that fingerprint of chromatograms for ginkgo. So you've got 33,000 ginkgo products on the market. And so to think that somebody takes a high quality material that's been demonstrated to have a certain quality and put it into a trial and shows that it does something good, and then try and extrapolate that single study of that single ingredient, proprietary ingredient, to that 33,000 ginkgo containing products on the marketplace, when most of them are not going to chemically look like that one that was studied. That's the reason why that's the reason why other agencies are not going to look at borrowed science is the derogatory term. So you can't steal somebody else's results that they've done on a ginkgo study for your own ginkgo product if it's not the identical product. And by identical product, I mean not just the ginkgo material itself, but whatever else is in the product with the ginkgo. So if there's another herb, Mary was looking at some of the products on ephedra, Dr. Hardy. And, the difference between ephedrine and ephedra that was on the marketplace is ephedrine hydrochloride for the most part. The materials that were on the market as ephedra often had fairly high levels of caffeine in the product. Some of them had
diuretics and
golden
laxatives.
seal. And other things. So,
and
so
almost all of them have dietary laxatives too.
Yeah, exactly. So you can zero in on the ephedrine, and ephedra is actually fairly easy to characterize in terms of its active ingredients, ephedrine, pseudoephedrine, some other stuff. But then when you add in the other herbs, to make a claim, an ephedra-based claim on a product that has more than just ephedra in it is not scientifically sound, and other agencies will not go for that. So, Federal Trade Commission frowns on studies on claims done on somebody else's science, on borrowed science, because of the differences in formulation, the differences in quality, the differences in number of ingredients on the marketplace. If it was vitamin C, just pure vitamin C, you've got the correct isomer of vitamin C, and it's just vitamin C. That's a different story. But the botanicals and even the non-botanicals, things like chondroitin, can be much more complicated. So I hope that answers the question to some extent. It's the nature of the marketplace more than anything else.
Great. Thank you, Dr. Betz. Thank you, Dr. Mary. Dr. Mary, I see that there was one more question in the Q&A for you. If you want to address that, you can just type it in, because we are now moving into session 4. So I am going to thank you all. And
thank you much for the invitation. It was wonderful. Lots of fun.
Great. And I'll turn it over to Jamie and Edwina.
Well, thank you so much. That was a beautiful session. Now, welcome again to session 4 of the Practicum, titled Rigor and Reproducibility of Dietary Supplement Research. This session will be moderated by Dr. Sanem Coskun, who joined the Office of Dietary Supplements as a scientific consultant in 2020. Dr. Coskun is a biochemist who supports the ODS in the MRAM program that Jamie was talking about yesterday. Take over, Dr. Sanem, and thank you very much.
Hello, everyone. Welcome to session 4. I'm sorry for my look.
James, can we do anything about this?
To adjust that, you're going to want to go to your video settings.
Okay, sorry. Yeah.
So now you just need to stop floating on the ceiling.
Yeah, down in your video settings, you'll want to go where it says start video. There's a little up arrow. Click on video settings from the menu that pops out. And
Yes, I did.
In the corner of your, it should be a little icon in the upper right corner of your video preview window. It'll
Okay,
let you,
sorry.
There you go. All better.
Yeah. Sorry for that. So welcome everyone for session 4 of the Practicum, Rigor and Reproducibility in Dietary Supplement Research. We have 2 speakers in this session, and after each session, we will have time for the questions. And please use the Q&A box for your questions, and for technical questions, you can use the chat box. It is my pleasure to introduce our first speaker, Dr. Adam Kuszak. Dr. Kuszak joined Office of Dietary Supplements in 2014. He is a health scientist administrator, and since 2018, he is the director of Analytical Methods and Reference Materials Program. Through this program, he works with stakeholders involved in research, industry, and regulatory affairs to support scientific resource development and promote biomedical research on mechanisms and health effects of dietary supplements and natural products. I would like to welcome Dr. Kuszak with his presentation on analytical characterization of dietary supplements, methods, standards, and quality assurance. Welcome, Dr. Kuszak.
Well, thank you for the kind introduction. It's a pleasure to join you all today. Let me start sharing. And can I just get a verbal confirmation that the sharing is working?
Not right now.
Okay. Let's see. 1 second.
Yes, it is good now. Thank you.
Okay, thank you. All right, well, as I said, thank you very much for the introduction. And I'll be, as you see, talking today a lot about a broad topic in terms of analytical characterization. I have to say it's really nice to see the Practicum expand in its speakers and topics this year. And part of that means that a lot of things that I will be talking about today have been touched upon, introduced in prior talks, and also there'll be some follow-up on these general ideas in some of the later talks. So I hope I'll be able to give a little bit of reinforcing repetition in some areas, but also provide some other perspectives on these topics. Just quickly, I have no disclosures to make on this material, and as an employee of NIH, I have to also say that the views expressed are my own, not representative of NIH positions. So for today, our fundamental question that I'll be posing is, how do we really get an idea of what exactly the dietary supplement is that we're investigating as researchers? Our objectives are to understand dietary supplement characterization, go over concepts of identity, purity, quality, and composition, and we'll discuss analytical challenges and needs, outline the use of reference materials and reliable analytical methods that are there to support rigorous and translatable dietary supplement research. Now, as we've kind of been hearing about in the program so far, one of the core issues here and challenge that we face is the fact that by definition, dietary supplement formulations can be very chemically complex. We've heard the regulatory definition. We've been seeing examples of how dietary supplements cover a lot of ground compositionally: vitamins, minerals, metabolites, plant material, fungi. And of course, the supplements can contain ingredients from each of these categories, and this complicates how you can analytically characterize their composition. As noted earlier in the program, the inclusion of botanicals as dietary supplements brings additional layers of complexity to standardization and quality assurance. And dealing with the variety of formulations like tablets, liquids, and gummies, this also can add significant analytical challenges. So what do we mean when we're talking about supplement characterization and product integrity? Generally speaking, a quality product has the desired ingredients, it meets labeled amounts, and it is free of contaminants. To get a little more technical, product integrity entails 4 fundamental parameters. And those are identity, purity, composition, and quality. So each of these important parameters presents analytical challenges which manufacturers and researchers need to consider. So let's start with issues in identifying dietary ingredients. And the first step there is naming. So imagine that you want to research the clinical effects of coenzyme Q10 supplementation. You go looking for a supplier of coenzyme Q10, and as we heard about prior, it's probably no surprise that there can be many different accepted names for the same chemical entity. You might see ubiquinone, you might see beta-carinone, but we need to be careful in this area. So in this example, you might see adiminone among those listings of CoQ10 reagents or supplies. But that is a synthetically derived analog of CoQ10. So it has a different chemical structure, and that difference might influence the results of your research. Now, botanical ingredients bring their own complexities in naming as well, and this can create confusion when sourcing ingredients or experimental interventions. Again, we heard a little bit about this where there's estimates of some 3,000 or more plant species sold in commerce, and naming does not always equal identifying. We can take a look at curcumin ingredients for an example here. So accepted common names for turmeric might equate one species with a wholly different botanical. So for example, turmeric being equated with a version of saffron or a version of ginger. Scientific names can undergo revisions over time, and there might be more than one commonly used Latin binomial. And there are also pharmacopoeial names and traditional medicine names to be aware of. So the potential for confusion around common or regional names, this can play out in the global supply and trade for botanical ingredients. This table here, it indicates instances where several unrelated plant species are all colloquially referred to as some type of a regional ginseng. And they've all been found to be sold as simply ginseng. So by calling it only ginseng, then that confuses these different plants, these different ingredients with Panax ginseng. Naming issues can also arise because plant identification is often based on morphological features, not chemical composition or genetics. Sometimes the distinct species that have similar names can be benign. So for example, German and Roman chamomile, and they have significantly different chemical compositions, but they're both acceptably sold as just chamomile. However, in the case of star anise, the fruit of Illicium verum, or Chinese star anise, has culinary and medicinal uses, but the fruit from Illicium anisatum, or Japanese star anise, and Illicium lanceolatum, these contain toxic constituents. Now, of course, identification challenges for botanicals also increase as ingredients are increasingly processed. Manufacturers and researchers are routinely faced with the question of whether a finely ground powder or a liquid extract is the desired botanical ingredient. For example, are all or any one of these powdered ingredients the golden seal that you might want to be using in the manufacture of your supplement? Or a question of what is the true composition of the green tea, spirulina, and moringa mixture of a green powder supplement that I want to be studying in health effects research. So in these instances, the botanical characterization, we're not able to look at the defining morphological features for what is the plant, but really have to turn to analytical chemistry approaches for these answers. Now, turning to purity and compositional considerations, different supplement ingredient types, they pose additional questions to manufacturers and researchers. With nutrients like vitamins and minerals, we need to be aware of different isoforms and chelation states, and then whether those ingredients are bioactive and bioavailable in those different forms. For botanical preparations, we need to ensure the use of the proper plant part, also assure the absence of harmful microbes, pesticides, and toxins. And the detection of undeclared active pharmaceutical ingredients, for example, PDE5 inhibitors or stimulants, this continues to be a known concern for certain types of products that are marketed as supplements. Now again, botanicals present further challenges to the questions of composition. We again heard a little bit about this earlier, that while botanicals that are used in traditional medicine and dietary supplements, they do have characteristic chemical profiles, and they have unique constituents that may have key bioactivities. The variability in the concentrations and ratios of these constituents is quite extensive, really driven by differences in plant part, different harvest conditions, and especially differences in the processing. So we can see a couple examples here, looking at a comparison of concentrations of key constituents like rosin and rosaverin in different rhodiola rosea extracts, or dramatically different amounts of certain compounds from different Echinacea purpurea extracts that are found in commerce. So as a result of these many variables, it can be quite challenging to measure and maintain consistency in finished products. Even so, it is the manufacturer's responsibility to set specifications for what determines quality. For example, a manufacturer might set minimum concentrations for active or marker compounds, and they should be setting specifications for limits on contaminants. We heard a little bit yesterday about how current good manufacturing practice regulations, they outline manufacturers' responsibilities to establish specifications for the identity, purity, composition, and strength of their products, and how this also includes testing of the incoming ingredients and outgoing products against those specifications. So we'll learn more about GMPs from Dr. Allen tomorrow, but one thing that I want to call attention to today is that the regulations, they don't mandate a particular method or technology be used in testing. They instead stipulate that the methods must be fit for purpose and scientifically valid. These are concepts that we'll come back to shortly. Now, in the context of biomedical research on the health effects of dietary supplements, the analytical characterization of experimental interventions is essential for rigorous basic and clinical research. So, heard about this earlier as well, where whether you're studying mechanisms of action, metabolism, safety, or ultimately health outcomes, the thorough characterization of reagents is a critical component to building research reproducibility and comparability. If we think back to the example with Echinacea extracts, if these particular constituents are driving a health effect that's under investigation, then a research study that is examining the effects of preparation number 5 here, you might really expect it to see dramatically different outcomes compared to a study that's looking at preparation 18 that has a very different proportionate profile of these key constituents. And you'd have to understand that chemical composition differences in order to really understand the research results. So there are the challenges in characterization and multiple guidelines for researchers that outline the importance of carefully assessing the composition of natural product-derived interventions, such as dietary supplements. For research funding, NIH stresses the importance of authentication and batch-to-batch reproducibility for research materials, as well as quantification and standardization of bioactive compounds. And I think these concepts of sufficiently characterizing dietary supplement preparations that are used in research are also going to come up in presentations later today that talk about recent studies on botanicals and health effects. Now, what do we need to do for testing to address these characterization challenges? Recall that the regulations don't specify how to test products, but they require that analytical methods must be fit for purpose and scientifically valid. Now, a fit-for-purpose method is a method demonstrated to be sensitive, accurate, precise, and specific for what it is that you're measuring, and also a method whose measurements are shown to be reliable and reproducible. A wide array of analytical methods are commonly employed to identify and quantify dietary supplement chemical constituents of interest. There are chromatography methods for chemical separation, spectroscopy and mass spec approaches to measure and quantify specific analytes, and various combinations of these techniques. There's also genomic analyses to investigate natural product sources and identity. Combining analytical methods that might be needed for more informative analyses of the multi-component formulations we often see in supplements. So for example, having a chromatographic separation of many different phytochemicals in an extract or in a powdered material, followed by then targeted mass spec analysis to quantify individual chemical peaks. Non-targeted analytical methods are being developed which can statistically classify samples based on their chemical or metabolomic fingerprint. So for example, a near-infrared spectroscopy data that was then used to model whether those powders we saw earlier were indeed golden seal root or a different adulterating species. And DNA-based analytical methods are also being increasingly applied to test dietary supplements. And I think it's important to note that while genetic techniques can be a powerful approach, like all testing, one must carefully consider whether they're fit for the purpose they're being used for. DNA analyses are not going to differentiate between plant parts. They're not going to tell you about chemical composition. And the data analysis can be confounded by extensive hybridization commonly observed in plants. But there is growing value in genetic analyses when applied appropriately. Sequence reference libraries are becoming more robust in their content and ability to differentiate plant species. And next-generation sequencing approaches are proving useful as a complementary method along with chemical characterization. Now, while manufacturers are responsible for testing, there are many third-party laboratories and contract research organizations who offer analytical services to help companies comply with regulations and ensure product quality. There are also some voluntary independent certification programs available to manufacturers. So the NSF International, we saw a logo for them earlier, they offer testing services to verify ingredient claims and ensure certain contaminants are not present. The USP certification program performs similar testing, and it also audits manufacturers for compliance to good manufacturing practices. The supplements that undergo those third-party audits, they likely have those on the label in some fashion. And we'll hear more about these testing topics from Dr. Yu at USP and Dr. Cooperman at consumerlab.com tomorrow. So with these concepts under our belts, let's take a look at a brief example of characterizing a product against a set of specifications. So the United States Pharmacopoeia monograph, this is one standard resource that establishes a definition of what constitutes quality for a ginkgo biloba leaf ingredient. So it outlines key chemical analytes and concentration ranges for both desirable and potentially harmful constituents, including flavonol glycosides, terpene lactones, and glycolic acids. Now, different analytical methods can be applied to a powdered ginkgo leaf sample to ascertain whether a manufacturer's specifications for the ingredients have been met. So here's a liquid chromatography separation and mass spec quantification of flavonoids and terpene lactones. And then also the same constituents alternatively detected using thin layer chromatography. And here note that no single analysis is quantifying all of these important analytes. multiple complementary methods are needed to sufficiently characterize dietary supplement ingredients and products. So now let me pivot to describing some efforts at federal agencies that support and advance dietary supplement characterization. Scientists at USDA are developing novel analytical methods to identify and authenticate botanical ingredients. Some of that work is supported by the NIH. FDA scientists are routinely developing new analytical methodology, often with a regulatory focus of identifying adulterants and contaminants. And the National Toxicology Program at the National Institute of Environmental Health Sciences, they have a program that evaluates the chemical composition of botanicals as a part of broader efforts investigating possible toxicities. At the NIH Office of Dietary Supplements, we have curated a selection of reviews, guidelines, and resources covering the topic of analytical characterization. So natural product researchers can look here as a starting point for good practices in experimental design and compositional assessments. ODS also co-funds some databases to add researchers in chemical characterization and verification. For example, a magnetic resonance database for natural products, and also an upcoming USDA botanical metabolomics database. Now, the ODS Analytical Methods and Reference Materials program is specifically focused on supplement characterization. AMRAM has three main program areas: method development and validation, reference material production, and laboratory quality assurance exercises. These different activities are designed to work together in order to help scientists characterize botanical ingredients, a supplement product, or a research sample. And the goal really is to support an enhanced foundation for rigorous research and industry analysis. AMRAM's resources are intended to meet the needs of the whole analytical community, helping them in their efforts to determine the composition, to assess quality, to develop standards, and comply with or enforce regulations. So I'll describe some more how the different AMRAM program areas support the characterization and understanding of dietary supplements. The USDA studies shown here were funded in part by ODS, and they illustrate method development to help authenticate black cohosh based on assessing certain key constituents. So just highlighted here, some constituents like caffeic, ferulic, and semisulfugic acids. So these constituents were separated into a chemical profile by a liquid chromatography method. And then the USDA researchers demonstrated how their observed ratios could help in differentiating different but related Actaea species. Now remember that it's important that a method is fit for its intended measurement purpose. And this fitness is demonstrated by thoroughly assessing a method's accuracy, precision, specificity, reproducibility, and some other factors. Assessing these key performance parameters is the basis of method validation. And the AMRAM program supports formal method validation in a couple ways. ODS has funded grants to researchers to support the performance of validation studies for their analytical methods. And these grant funding opportunities are focused on methods that quantify chemical constituents or their metabolites or adulterants that might be found in the dietary supplement preparations, characterizing them in either experimental reagents or clinical specimens like plasma and tissue. The resulting research publications highlight the development of novel methods. So, for example, liquid chromatography and mass spec quantification of sphingosines under investigation for chemopreventative activity, or gas chromatography and mass spec characterization of a complex mixture of grapeseed flavonoids that are being studied in models of stress resilience. So in these cases, the formal method validation adds confidence to then the biomedical research on the links between these dietary ingredients, their metabolites, and then the mechanisms of action that they're touching upon and their health outcomes. From 2013 to 2018, NIH ODS contracted with a standard setting organization, AOAC International, to catalyze development of consensus-based official methods of analysis for characterizing chemical constituents in popular dietary supplements. These methods can be found online, and they're available for both industry and researchers to use. Now, for the next AMRAM program area we'll get into, reference materials for dietary supplement characterization. These are authenticated, homogeneous preparations with well-characterized composition or properties, and they've been established to be fit for their intended use and measurements. So, for example, these reference materials in these bottles here for ginkgo biloba leaves, they have a known true certified value for the content of flavonoids and trace toxic elements. So reference materials are intended to help analysts and researchers to verify the accuracy of their measurements and support the development of new measurement methods. To date, some 50 matrix-based reference materials have been created through the AMRAM program. They cover many of the most studied and popular dietary supplement ingredients, including multivitamins, fish oils, and many botanicals. Here's an example of a reference material use in action. So AMRAM contracted with a company to produce a mixture solution of 9 key constituents of the botanical kava. So this mixture was developed with known quantities of specific kavalactones and flavocavanes, and this allows its use as a calibration standard for methods that separate out and quantify the constituents of kava. These chromatograms here then confirm that a method is able to separate key constituents from both a kava root extract and a capsule product formulation, and seeing where the peaks from those different preparations align with the reference material standard peaks. And because the reference material has a known composition by mass, then the amount of each constituent in the kava ingredient and dietary supplement can be determined. So in this way, reference materials provide researchers a means to test, improve, and validate their measurement methods. The final AMRAM area that we'll go over is the administration of laboratory quality assurance programs. And this is done through collaboration with partners at the National Institute of Standards and Technology. So these quality assurance exercises are voluntary, non-regulatory program, and they provide a means for a community of labs to identify analytical problem areas, to compare their methods, and then also reduce biases in their measurements of compounds relevant to dietary supplements, such as nutritional nutrients, fatty acids, botanical phytochemicals, and the like. As an example of one of these quality assurance program exercises, here participant labs measured curcuminoids in turmeric rhizomes and extracts. So a certified true value for curcumin content in a turmeric rhizome preparation reference material is indicated by this black line, and a targeted analytical range shown within the orange lines. So in this way, the participant labs along the x-axis here, they could see where their measurements fell along the targeted true amount of curcumin. And then the labs who fell outside of that range, well, they could then work with scientists at NIST to understand why their results differed. So with that overview of the AMRAM program activities, for the remainder of my time, just highlight a few examples of how these resources have been used to improve dietary supplement characterization and our understanding of health effects. So here's some data from ODS support for method validation studies. This helped teams at the Washington State University and the University of North Carolina comprehensively characterize major and minor alkaloid constituents in kratom products, and also investigate the pharmacokinetics of kratom constituents and their metabolites in plasma. So their studies were able to advance our understanding of the pronounced pharmacokinetic differences between individual kratom alkaloids. And this helps lay a solid foundation for further clinical studies of safety and health effects for different kratom preparations. AMRAM-supported reference materials are used in the generation of estimates of nutrient and phytochemical exposure from dietary supplement intakes as well. The dietary supplement ingredient database, which will be described in much more detail in one of this afternoon's breakout sessions. This program analytically measures the contents of prioritized supplement products sold in the US and compares those values to the label claims. So the DSID uses reference materials in their studies of botanicals like green tea. Here's an example of a lab's quantification of EGCG and caffeine in a green tea reference material compared to the true certified value. And this assurance of measurement reliability then adds confidence to subsequent investigations of the dissolution and disintegration of various green tea product formulations, which showed that certain products have a substantial release of the catechin content, and other formulations seem to be lagging behind the release of that content. So by knowing that the method is accurately measuring the catechin EGCG content here adds a lot more confidence to these studies. Now, I mentioned the National Toxicology Program earlier, and this is a slide where we saw earlier in Dr. Betz's talk a zoomed in portion of this, but zooming out also then as a means to show where the researchers used a ginkgo biloba extract reference material, shown on the bottom here, as an authentic control material when they wanted to take a look at identifying appropriate commercial samples for their toxicity studies. So the NTP researchers were able to confirm that some of the samples indeed had profile traces indicative of the presence of ginkgo biloba. But as you saw, some of these traces are completely lacking in the key marker constituents for ginkgo biloba quality. So therefore, they were able to conclude that maybe there is a toxicity concern for a particular product that is one of these, but they'd also be able to say that, well, that's not really a representative of ginkgo biloba's chemical composition. So I hope I've shown how ODS resources for dietary supplement characterization have promoted accuracy in testing and have enhanced analytical capabilities for researchers. These are integral pieces to ultimately support more evidence-based dietary supplementation practices, and also to better inform policies. So I've covered a lot of ground today. Main takeaway being that the chemical composition of dietary supplements can be very complex, as we've been hearing. Combinations of multiple vitamins, minerals, protein, fatty acid, botanical ingredients, they make chemical analyses quite challenging. And the inherent variability of botanical ingredients in the chemistry means that key bioactive or marker compounds of a formulation can vary across different preparations. So with these challenges, reliable research and consistent product quality depends upon thorough characterization of supplements used in clinical investigations and sold on the market. And there are multiple programs and resources that support thorough characterization to promote rigorous research. So I tried to show a lot of examples of research data today, and that wouldn't be possible without the work of many people, my colleagues at ODS, as well as teams at USDA, NIEHS, NIST, and Cerilliant. And I also highlighted work from University of Washington and North Carolina UNC Greensboro. So I thank you for your attention. It's been my pleasure speaking with you today. My contact information is here, and I know it'll be provided in the practicum materials as well. So if we have time, I'm happy to take questions.
Thank you so much, Dr. Kuszak. We have a few questions coming up and we have some time. So the first question is, what options are available to manufacturers to confirm the identity of dietary supplements they buy? Any specific testing that is recommended over other types?
Yeah, that's a big question. Can you repeat it one more time? I just want to be sure I'm touching all of it.
Sure. What options are available to manufacturers to confirm the identity of dietary supplements they buy? Any specific testing that is recommended over other types? Like any more specific testing is better than the other ones?
Right. I think where I will start is in that perspective of a manufacturer sourcing ingredients for their products. They can look to a number of what are known as pharmacopoeia monographs. And so I talked about United States Pharmacopoeia, for example, their monograph for a powdered ginkgo leaf preparation. And that monograph, we talked about how it specifies, look at these analytes. A ginkgo leaf should have not less than this percent of a particular analyte, perhaps not more than this percent. They will also, in the monograph, describe analytical tests that they would recommend performing. And they also, United States Pharmacopoeia is also a supplier of reference standards that the manufacturer can use to be sure their tests, their analytical methods are working appropriately in their hands. The reference materials that you can use against tests that I highlighted today are intended to be fit for purposes of other types of testing. So the labs, the manufacturer lab or the research labs can use reference materials from a variety of sources to test that their methods are working appropriately. And then there are some other sources of consensus expert reviewed methods that they can also look to as well. I mentioned AOAC International is one standard setting body that they could look to.
Thank you so much. Another question. Dr. Kuszak, could you please suggest a database for botanicals that are planned to be used as dietary supplements for protein and anti-nutritional factor footprints?
That's an interesting question. I don't know of a type of listing or database that is specific to the kind of context of that question. It sounds like there's a question of either what are quality botanical, plant-based protein sources, or maybe it's a question asking a bit about how to be testing for those approaches. I'm not sure of any type of listing that would point you to, use this plant, not that plant type of a thing, but to the question of how to be testing those for protein content, how to be trying to test, is this really pea protein versus soy protein or things like that. Similar answer to before in terms of some of those sources for looking at official methods or reference materials.
Okay, thank you. Another question, in the event of there is no monograph in the pharmacopoeia, or if there is no reference material, how can the manufacturer establish a product specifications or characteristics?
Right. Part of that is somewhat it depends, which is to say, we talked about how it's the manufacturer's responsibility to set the specifications, and kind of wrapped it up into that is their decision of what specifications to be setting. And they need to be specifications that they can then be testing for in some way. So if there's not an official method for something, if there's not a reference material for something, that then becomes the onus on the manufacturer to figure out what to be setting, for example. So to make up a hypothetical, if a manufacturer is saying, well, I have this, particular plant, and I think it's really important that it has this percentage of a particular constituent as part of my quality specifications, then it's up to that manufacturer. If they're going to set that specification, they need to have developed a method that will tell them what is the percent of that particular constituent. And then there are processes they would go through to validate that method that's giving them the true answer. And so it really is up to them to figure out what to be specifying and then identifying appropriate reference materials to be sure their method is correct. If they are not, if there is no reference material for that, if they're not taking it upon themselves to develop the method or things like that, then I guess I'd opine that they probably shouldn't be setting that as a specification.
Okay, thank you. Can you emphasize the definition of a constituent as being a chemical compound and not part of a molecule? Use the cast as an example, please.
Okay, so I think the answer there is I may have been just kind of colloquially using the word constituent a bit broadly to kind of encompass individual chemical entities that one could be looking at in the either targeted or non-targeted chemical profiling. So the main thing that I was trying to get across is, what analytes are you looking at? What measurands are you looking at? Some different words, but the basic idea of what are you measuring? Are you measuring flavonoids in some way with a type of a test that can get at that? Or are you measuring a very specific chemical entity? Again, it really depends on what it is that you're interested in for standardizing your preparation, or what it is you're interested in measuring for your health effects research and the like.
Okay, another question. Should the identity of Botanical be tested for every batch or only during the first few batches?
I think that part of that is if you're a manufacturer, I don't want to speak for FDA, but I believe, each batch is to be tested. I don't think you can, in the regulations, again, I'm not at FDA, but I think testing of each lot or each batch is part of the requirement. If you are a researcher, then what we see often in research is that a particular study will try to use a single batch in the duration of their study. They'll try to create enough of the intervention in a single batch for the duration of the study. So they then testing of that, and what becomes important is being sure that you're looking at the stability of the preparation over time, over the duration of the study, testing it in that way. And then if you do another study, or if somebody else does a study, you'd want to be testing that new preparation as well.
Okay, more questions are coming. Maybe we have one more time for one more question. Dr. Kuszak, would it be feasible to dedicate a central testing laboratory service within the NIH serving dietary supplement formulators?
Yeah, interesting question. I'm not sure how feasible that would be. Again, just my own opinion here. If something were established at NIH, I think a large focus on it would be providing a service for the researchers more than a service for industry. But it's an interesting thought. I don't know that I can speak too much to the overall feasibility of that. Actually, I see Barbara Sorkin, our next speaker, with her hand up, and she'll be talking about some certainly NIH organized supported efforts, and maybe that's a perfect transition for me to kick off and allow Barbara to respond to that and then go into her talk. Thank you, everybody.
I will just say very briefly then, thanks, Adam, that has been discussed, and at the time it was, last time I saw it discussed, it was decided that it was not feasible, even just for NIH-supported research, because of the wide variety of products of interest.
Okay. Thank you so much for addressing this, Dr. Sorkin. I don't want to take more of your time from your talk, so there are a few questions, Dr. Kuszak, if you would like to answer from the Q&A box. Thank you for the great talk. And now I would like to introduce our next speaker in this session, Dr. Barbara Sorkin. Dr. Sorkin also works for Office of Dietary Supplements. She is the co-director of the NIH Consortium for Advancing Research on Botanicals and Other Natural Products program, which is a collaborative centers program focused on advancing the scientific base of knowledge about the chemistry and biological activities of botanicals and other natural products. Dr. Sorkin will talk about how concepts of efficacy, safety, and identity are addressed in studying botanicals and plant-derived ingredients, and provide an overview of the NIH Centers for Advancing Research on Botanicals and Other Natural Products program. I would like to welcome Dr. Sorkin to discuss the challenges in research on botanical dietary supplements. Welcome, Dr. Sorkin.
There, now I'm unmuted. Thank you so much for that lovely introduction, Sanem. And trying to find my, there we go. And full screen and okay. And I want to thank all of you who are still hanging in with us at this point for your interest in our supplements practicum, and in particular on botanicals. I should disclose that I do work for the NIH. My views are mine and not of the US government. I have no financial conflicts of interest to disclose. I am strongly biased in favor of having lots of rigor and integrity in research. So full disclosure there. And I want to thank Adam for introducing, and all the speakers really who preceded me, concepts that I'm going to use in my talk, in particular the importance of understanding the chemistry of these chemically complex botanical dietary supplements and the challenges that their complexity and their inherent variability pose to the research, among other things. Those are not the only things that make this research challenging. As we heard from Dr. Dwyer yesterday, when people take dietary supplements, for example, if someone's taking echinacea, they're taking it, unlike with a strawberry, where you're consuming the strawberry because you want the strawberry, although even there, you want the strawberry for its flavor and its sweetness, and if it doesn't have those, it's not really the strawberry you wanted. Again, with the echinacea, you are probably taking it not for its flavor, not for its sweetness, but because you think it will protect you from colds or shorten the duration of a cold that you already have, which is more treatment than perhaps than health immune system support. But so the question that we really want to ask is not, is it really echinacea, but is it the right composition of echinacea or whatever the botanical dietary supplement is to provide the health effect that you're looking for? You heard from a number of speakers that the the gold standard for figuring out whether something has efficacy is a clinical trial. But with echinacea, because of the number of chemicals in it, that's a little more challenging. And it's not just the number of chemicals in it or their variability from one batch of echinacea to another, but it's also that when you're using echinacea, unlike with a drug that's been developed by a pharmaceutical company, you don't necessarily know what the active chemicals in it are. If its use is based on traditional medicinal system or on folk use, on current common use, not only do you not necessarily know what the requisite chemistry is, but as you heard from Dr. Betz's wonderful talk, the outcome that it's traditionally used for may be balancing the humors or the doshas, or decreasing vapors, or dampness. And you don't really know how to test for that. In a clinical trial, you don't know what the in vivo target for that is that you need to occupy with your active chemicals that you also don't know. So you have a bit of a chicken and an egg question. Unlike with a drug where you usually know what the molecular targets are that you need to target to affect what the health effects that you're trying to achieve. And you may have, certainly you know the clinical outcomes that you're looking for. So how do you deal with this chicken and egg question? We've already heard the gold standard for showing efficacy is to do a clinical trial. So why don't we, just to show that these botanicals are effective, just jump in and do clinical trials? You've heard some of the reasons why not. Some of my skepticism about doing clinical trials is exemplified by this table. It's sort of a joint effort at this point between Craig Hopp at the National Institute of Health's National Center for Complementary and Integrative Health, and I've sort of summarized it here. What it summarizes is, and you saw some of these before from Dr. Betz, phase 3 clinical trials of botanicals that were supported by the NIH, some of them also by the Office of Dietary Supplements, and were published in the early 2000s. About a dozen different botanicals, somewhat more different outcomes that were looked at. The take home is that the vast majority of them showed no statistically significant difference between the intervention and the placebo, and those that did show statistically significant differences, I would argue that the differences that they showed were not clinically significant. Okay, well, that's very useful if that changes practice. But as I'm sure you're all aware, these botanical dietary supplements are still very much in use. So it didn't change practice. Why didn't it change practice despite these phase 3 clinical trial results? Because when those trials were finished, people said, well, it wasn't the right formulation of ginkgo. You should have standardized it on different compounds. You should have combined the saw palmetto with something else. You didn't look at the right outcome. You didn't use a high enough dose. Now, I was coming to the NIH around the time these clinical trials were being published, and I am absolutely sure from having run into them that the people who designed them were very confident that the research base on which they were basing their designs was solid. They were basing them on prior small clinical trials that had shown benefit using as the same, or if not quite the same because it wasn't feasible, as similar a product as they could manage using the same outcomes. But in fact, when you looked back at those lower levels of the pyramid, the animal and in vitro studies, in fact, those data with 2020 hindsight were not really as solid as you would like to support a clinical trial. So the people who said, yeah, you didn't really do the right clinical trial, you couldn't say that they were wrong. So in fact, as Dr. Sesso said earlier, you really only want to do a clinical trial when you have, and as these authors have recently said in the JAMA guide, you really only want to do a clinical trial when you have reasonably strong reasons to believe that the results will either, I would say, change practice or represent important new knowledge. And as you've heard from the people who talked before me, some of the places where that, and I would add that the other, that you're more likely to change practice if the outcome you're looking at addresses an unmet health need. Certainly you're looking for prior research that shows strong evidence of benefit, among other things. So where do those supportive outcomes that justify spending taxpayer money if you're funding something through the NIH, where do they come from? Epidemiology, which you've heard a lot about. Ethnobotany, if you come to breakout session 2C, Botanicals and Health a little later this afternoon, you'll hear about ethnobotany. It's not only something that's done in the Amazon, as shown in this photo, but also very much in the 20th century in major cities in the United States and other developed countries. A lot of the data, as Dr. Sesso said, to support clinical trials comes from mechanism of action. That's not what I wanted to do. Mechanism of action data can really help you with those questions that are often unknown for botanical dietary supplements. What chemicals do you need to have the health effect that you're interested in? And where do they need to get to in the animal? Are there biomarkers of target occupancy or activation that you can actually assess in a clinical trial? Those data are often initially developed in vitro or in animal models, non-human animal models. They can come from early phase clinical studies of mechanism of action in humans or smaller clinical trials. And this is summarized to some extent in this graphical outline. You need to know what the chemistry of your product is, which chemicals in the product you need to exert the effect on what you're interested in, usually a human health outcome. Are the chemicals that exert that human health outcome, are they in fact present in the starting material in the botanical product, or do they need to be broken down either through spontaneous chemistry by enzymes in the consumer, by enzymes in the consumer's gut microbiota? Where do they need to get? Is it sufficient for them to interact with gut microbiota, or do they need to get into the central nervous system and interact with transcription factors in the microglia in that central nervous system? So all of those things can help you both design a clinical trial that is more likely to show a benefit to support a benefit if there is a benefit. You can't tell from a single clinical trial. And that are at least is more likely to be readily interpretable if you fail to disprove the null. And there's a lot more detail on this in a paper that I led that was published in FACIT-J in 2020. It's in the resources list that I gave you. So here is a bulleted outline for the talk. And I want to start by talking about the Consortium Advancing Research on Botanicals and Other Natural Products, henceforth the carbon. You'll hear from two of the PIs and co-PIs from the carbon if you come to the breakout session 2C in a little while. I'll take you through some more product issues, especially as they relate to how you make sure that the product that you are using or studying is the product with the right chemistry to have the biological effect that you're interested in. Which of the many chemicals in it do you need to be really focused on, and what's the importance of looking at all of the others? How many others are there? You'll hear from Dr. Czech if you come to 2C about interactions between chemicals and their contribution to health. I'll talk about bioavailability and then some meta issues. And of course, what do you do with animal studies to make sure they translate to humans? So this is based on the Office of Dietary Supplements webpage summarizing the current carbon program. We also have links to former carbon centers that we had supported. There are currently, for 2020 to 25, five different carbon centers in 3 different flavors. I want to start at the bottom with the Natural Products Magnetic Resonance Database Center. And I should say that support for the carbon program is not only Office of Dietary Supplements, but also National Center for Complementary and Integrative Health and National Institute on Aging at NIH. So the Natural Products Magnetic Resonance Database is at this point a database containing more than 5 million different natural product NMR spectra from more than 280,000 different natural products. I urge you, if you are generating NMR spectra from natural products, of course, the right thing to do with your data are to share them, make them findable, accessible, interoperable, and reusable. This repository is as easy as any other repository, a place to upload them. It is obviously NIH supported and freely available to all to use. It incorporates tools that will help you interpret your spectra, understand what compounds they are most likely to correspond to, and learn about those compounds because it's linked to other databases that can tell you about where else those structures are found and what biological effects they have. In session 2C in the Botanicals and Health breakout, one of the co-PIs of the high content functional annotation of natural products, the HiFan Center, Dr. Nadja Chek, and you've seen some of her data already in this practicum. She will be presenting about what they do. So I'm going to be very brief about that. I'll talk a little bit more about it. And then we have 3 botanical dietary supplements research centers. And these are the 3 centers that are focused on using the resources from the database, the methods developed in the HiFan Center, and using them for specific small groups of botanical products to understand exactly what chemicals in those products, at what concentrations are most appropriate to use to see a robust outcome and what clinical outcomes are going to be most robust for those specific botanicals. So really the chemistry needs to be fit for use, to use Adam's term. Is it the right chemistry for the specific outcomes you're looking at? Because there may be multiple outcomes that you could look at. So turning then to the next thing on the outline, product, and I think you've already seen this. The point I want to make is not just the chemical complexity of turmeric, but the pitfalls of using a single characteristic of a chemically complex product like turmeric to standardize it. So the curcuminoids in turmeric are, of course, what are generally presumed to be the source of its immune modulatory effects. Janet Funk at University of Arizona has presented data, published data, that there may also be a contribution from the volatile oils in turmeric root. But what I want to focus on is the pitfalls of focusing on one characteristic of this chemically complex product when you are, can I make that go away? When you're analyzing it. So turmeric, of course, has this lovely golden color. And in order, as one method of economic adulteration of turmeric, if you're focusing just on the color, people have been known to add lead chromate, which of course is pretty dangerous for a product that is to be used for consumption. I want to spend a little time on what happens, another example of an economically motivated substitution, perhaps. It's surprisingly, perhaps, it is cheaper to synthesize curcumin, one of those curcuminoids, than to enrich it from turmeric root. And Botanical Dietary Supplement Research Center that we previously supported at University of Illinois, Chicago, in this Kim et al. Paper, were ended up consulting, not as part of their NIH-supported specific aims, on 20-some cases of acute non-viral hepatitis that were reported in the summer of 2019 in Europe associated with 20 different turmeric products. And they were able to see that, in fact, the products that were associated with the non-viral hepatitis were, in fact, synthetic. If they had been curcumin isolated from turmeric root, there would have been some presence of peaks from the dimethoxy and bis-dimethoxy curcumins. And there was absolutely nothing in these batches associated with hepatitis. So indicating that they were in fact synthetic, and presumably the cause of the hepatitis was residual organic solvents left in those synthetic products. turning then to figuring out which chemicals so that you can standardize to the chemicals you want. And I should say that, no, I'm going to wait and say that later. In trying to understand using in vitro assays how a botanical dietary supplement works, very often you're looking at single small molecules, phytochemicals, and what are the pitfalls associated with that? Well, often phytochemicals are thought to be have beneficial activities because of their antioxidant activity. Obviously, that makes them redox active. This is a wonderful paper by Jonathan Bale and Mike Walters in Nature in 2014, talking about some of the pitfalls of doing in vitro assays with these small molecules. It can be tremendously useful for getting information about mechanism of action, but it can also mislead you through the many chemical activities of these molecules, these pan-assay interference compounds, which include curcumin and the catechins that are found in green tea and many other plants. Some of the different ways that these chemicals can fool you is by interacting with the enzymes that may be used to generate the readouts from your in vitro assays. Sometimes the phytochemicals just decompose. Some of them can chelate metals that may be necessary for your enzyme readouts, and they can interfere also with photometric or fluorescence assays in a variety of ways. And this paper from Nelson et al., also in the resource list, describes not only the ways you can be misled by some of these very chemically active phytochemicals, but also controls, ways to avoid being having your assays confounded by them, and controls that you can do to ensure, to try to ensure that you're not being misled. So turning from elucidating mechanisms of action with in vitro assays to more efficacy-focused product quality issues. And you saw St. John's wort before. You've heard about the potential actives, including hypericin and hyperforin. Also, perhaps, according to Dr. Butterweck, from whose paper I got this data, the flavonoid glycosides may be necessary for mood-supporting activity, at least in rodents. But this is a cautionary tale from a study that was done with St. John's wort for ADHD in children. You can see that the study published in JAMA in 2008 found no difference between the St. John's wort and the placebo control. So did that mean that the St. John's wort didn't work for the placebo control? This is why it's so important to analyze your product. Yes, each batch of it, I would say, if you are doing research with it, to make sure that it is what it's supposed to be. Their product was initially standardized hypericin, 0.3%. They analyzed it because it was from a trusted supplier. They analyzed it after the trial. At that point, it was 0.13% hypericin. Even if they had thought that the active was hyperforin, it would have been too low a concentration. So the only thing you can learn from this study is to make sure that your product really is what you want it to be at the beginning of the study and throughout the study if you have concerns about its stability. Even if you don't have concerns about its stability, you don't ever want to be in this situation where you didn't reject the null hypothesis and you don't know whether that was because your product was insufficient. This again shows the variability in composition of a botanical natural product. This is from the Botanical Research Center we supported at University of Illinois Chicago, looking at Angelica sinensis and dongquai used around perimenopausal symptoms. Each of the 6 slightly different colored red-brown colors represents a different chemical in this extract made the same way from 24 different batches of Angelica. And you can see that the ratios of these different chemicals vary substantially from batch to batch. And because they are quite different in structure, as I'll show you in the next slide, you would thus expect each of these different batches, assuming that the different chemicals, they must have different activity, they're so different. Each batch would probably have different biological activity, even though they each correspond to the same weight of Angelica. And these are the chemical structures. So if it's so hard to work with these chemically complex botanicals, why do it? As I think many of you are aware, the tradition is that there are, in traditional medicinal systems, that there are multiple principles in a plant or a plant prescription that contribute in different ways to its health effects. And more recently, there are 21st century rigorous data showing that, in fact, there are multiple chemicals in a botanical that contribute in 21st century demonstrable assays to activities. Two of these papers are from Dr. Czech's lab. Again, she'll be presenting in the Health and Botanicals breakout session. This paper shows that whole Artemisia annua plant is more effective in a number of ways than artemisinin, the frontline malarial therapy. And this is a paper from a collaboration of two different carbon-supported botanical research centers. So how do you figure out which chemicals in a natural product to follow? Which ones are responsible for your biological, your health effective interest? The old-fashioned way was to isolate each of the chemicals in the product and do in vitro assays to see which one was effective. And very often, once people found one chemical that had activity, they would stop without looking for others. Also, if you're separating your chemicals and then assaying the activity, if multiple chemicals interact to produce the activity, you're probably going to lose that. Very excitingly, the HiFan Center has developed methods that I think really break through this bottleneck of needing to purify in order to figure out what chemical you have and whether it has activity. The methods they've developed allow you to look at a number of overlapping fractions from a natural product. They've developed methods so that you can look at the very complex mass spectra arising from those mixtures and understand quite well what the different compounds in the mixture are. And they've developed computational methods so that you can take your biological assay of choice, combine it with the chemistry, and draw very good hypotheses about which chemicals contribute to which biological activities. They've done a lot of work using cell phenotype and gene expression as their outcomes, and they've shown that they can draw stronger hypotheses, combining two different types of biological outcome. And of course, using untargeted outcomes like cell phenotype and gene expression allows them to see potential mechanisms of action that would not have been the ones they would have guessed from the botanical and the outcomes of interest. So let me keep moving. You can hear more about that from Dr. Czech this afternoon. I want to turn now more towards the consumer side of whether these things are efficacious and some of the ways that doing botanical studies in humans can be particularly complex. Some of these also apply to studies of drugs. Adam showed you the importance of making sure that your botanical actually gets out of the capsule. Clearly, if it doesn't, in this case for green tea, epigallocatechin gallate, with 5 of 11 over-the-shelf green tea products, probably not releasing enough to have an in vivo effect based on these data. Moving from the capsule to the consumer, this shows the extent to which different diverse humans can be affected differently by the same natural product. This is from the Botanical Dietary Supplement Research Center focused on grape products, supported through the Carbon at ICOM at Sinai School of Medicine and Rutgers University. This is a collaboration also with Janet Novotny at the US Department of Agriculture. What you're looking at here is the plasma levels after a bolus dose of their grape product on days 1 and 11 of dosing the product daily. And you can see that on day 1, the open shapes, you get modest levels of the product in either their group of 6 people with healthy BMI or their 6 people with high BMI. But on day 11, you see much higher levels in the person with the healthy BMI, the lower BMI. So the take home here is that the effect of a dietary supplement is dependent both on the dietary context of the individual consuming it and also on their personal characteristics. And these data are not just true for the catechin that they were looking at there, but also for epicatechin and resveratrol, and to a much lesser extent probably for quercetin. One of the very important ways that we try to understand the effects and mechanisms of action, in particular of botanical, of any intervention with a human really, is animal models. There are all kinds of things that you can ask about in an animal model that you can't ask about in a human. You can look at bioavailability in all kinds of ways. There are things that you can do in animal models that you're allowed to do that you could not do in humans. But how well do the animal models translate to the human? You can see more about this in the FASEB-J paper. But really, there are a variety of ways in which mice are not just little humans. I've been pointing to the diversity of humans, and in research, mice are usually inbred. They're certainly maintained in relatively uniform conditions, although there are resources. This paper in particular talks about some of the ways in which those uniform conditions may be more variable than we think they are. One of the papers in the resources list talks about the ability to use the availability of outcross or diversity cross mouse models, which give you access to some of the genetic variability-based modulation of effects that you otherwise lose in mouse models, and you are still usually able to see an effect of your intervention if there is one. Among the many differences between mice and humans, including in their immune systems, are their dietary requirements. Not only are they fed different diets than humans in the developed world normally eat, but their nutritional requirements are different. Mice are able to make their own vitamin C. They don't require ascorbic acid in their diet. So the take home is not that we shouldn't use other animal models. Models allow us to access information that we can't access from the humans we're usually really interested in. The take home is, remember how your model is different from the question that you're really interested in, and how it's similar. And choose your model based on is it similar in the most important ways? Preferably use more than one different model, and use models that differ from your human population of interest in different ways if possible. The same thing for in vitro models. Think about which parts of your much more complex in vivo system are represented and which are not. Same for cell-based models. A little bit more about sources of human variation. I'm not going to talk today about the gut microbiota and their role, but this is about human genetic variation and diet. This is actually a secondary analysis of the VITAL trial. So Dr. Betz showed you some omega-3 fatty acid trials. VITAL was a trial that ODS helped to support. It was of vitamin D and omega-3 fatty acids, looking at cardiovascular outcomes. And the VITAL trial reported no effect of the omega-3 fatty acids, fish oil in this case, on cardiovascular risk factors. This is from a secondary analysis that was done by Floyd Chilton and colleagues of the VITAL trial. So this is hypothesis generating data. But in their secondary analysis, they confirmed what VITAL reported, no effect of the fish oil supplement on cardiovascular risk in the self-reported white participants in VITAL. But in the self-reported African-American participants, in those who were consuming fish less often, not in those who are consuming fish more often, but in those at relatively high risk in consuming fish less often, so low omega-3 fatty acids, presumably in their own diet, there they saw an effect, so far fewer cardiovascular events in those getting the fish oil than in those getting the placebo. So why would there be a difference between the white self-reported and African-American self-reported participants in the trial? The hypothesis that Dr. Chilton and his colleagues put forward based on research that they did with plant-derived omega-3s. They learned that there is, from that research, that there's polymorphism in the fatty acid desaturase gene cluster in humans. Those who have the one allele have much more active conversion of omega-3 fatty acids to lipid mediators that modulate inflammation. And in our Western diet, we tend to have a relatively high ratio of omega-6 fatty acids to omega-3 fatty acids, where the omega-6 fatty acids are mostly converted to pro-inflammatory lipid mediators, the omega-3s to inflammation resolving or essentially anti-inflammatory lipid mediators. So what does this mean? This means that because the polymorphism, the allele, that is the high converting allele, is almost 100% penetrant in African populations, a little bit lower in mixed populations with African ancestry, lower still in European populations, and lowest in Native Americans. So it's not surprising, in fact. What they expected to see was that, in fact, there is more inflammation-associated outcome, cardiovascular outcomes, in the African American population. And that you see more of an effect of the omega-3 intervention. Turning then, we've talked about product and really standardizing it on the chemicals that you need for the health effects of interest. We talked a little bit about understanding the more you understand about how the product works, the more you may be able to understand any variation in outcomes. But then there's some variation in outcomes, and you've heard a little bit about the placebo effect in dietary supplements. In fact, Dr. Betz showed you this St. John's wort for depression trial that turned out to simply show that placebo has a very strong effect in depression. One way to control for placebo effect is shown in this lovely study from Bruce Barrett and colleagues. It was published in Annals of Family Medicine. In their trial of echinacea for common cold, in addition to randomizing participants to echinacea or placebo capsules, they also had participants who were randomized to no capsules. So it was an unblinded negative control group. And they also asked, because they were interested in the role of placebo effect, at the start of the trial, they asked everybody whether they expected, what their expectancy was for echinacea, whether they thought it would help decrease their cold symptoms. And at the end of the trial, they asked everybody which supplement, whether they thought they got, those who were randomized, blinded, whether they thought they got the echinacea or not. And here are the conclusions blown up for you. Those who were in the no pill group tended to have longer and more severe colds, and those who reported that they had high expectations for the echinacea, as long as they received pills, their colds were shorter and less severe, regardless of whether they got echinacea. So it's a lovely demonstration of placebo effect. So to the extent that you look in the research that you are reading, that you think in the research that you are designing and doing about these product controls, about understanding the mechanisms of action and not getting misled by confounding effects, that you think about placebo effects and the role of individual differences in modulating effects, I think we'll have less of this kind of whiplash. And I hope more research that continues to build a solid basis for making practice decisions. Finally, some last take-homes. And some of these Dr. Betz covered. Look at the source of whether you're reading a news article about a paper or going to the primary biomedical research paper. It has been shown, look at who are the authors, where are they, what are their affiliations? It has been shown that authors who are employed by or otherwise benefit financially from the manufacturer, the producer of a product, are much more likely to find benefit of that product in their publications. Look for studies that are pre-registered, and if they're pre-registered, as required by many biomedical medicine journals, as required for all NIH-supported research, it's really easy to go to clinicaltrials.gov or even the Korean or Japanese clinical trial registries. You can get those in English. You can see them in English. And look at what the pre-registered trial says. Are they reporting in their publication the same number of people they pre-registered? Are they reporting the outcomes that they pre-registered as the primary outcome? If they looked at a lot of different outcomes and they're reporting something different, if you look at enough different outcomes, if you choose which outcome you're reporting after you've analyzed the results, and you're not correcting for multiple comparisons, you're essentially drawing the target around your arrow after you've fired it and hit the target or not. You heard about the, per protocol versus intent to treat reporting of clinical trials. Obviously, that can really affect your ability to the extent to which you see false positives, and the generalizability of what you report out. If the results are really surprising, if they don't make intuitive sense, look at whether the researchers or others have used methods based on different scientific principles, concepts, to test the outcomes and see whether they reproduce. So that's all zooming in. Finally, zoom out. Do the reported results make sense from an evolutionary or ecological point of view? What is the likelihood that a rare phytochemical found only in a tropical plant is really, really critical for human health through reproductive age? Makes it hard to explain the survival of the Inuit, right? And then one last principle that you probably know, and what are your questions? Let me stop sharing.
Dr. Sorkin, thank you so much for this wonderful talk. But we are a little bit out of time. So yeah, I have to just say, if you want to learn more about the research, we have breakout sessions are coming up, and Dr. Sorkin will be moderating one of the sessions. So I don't know, maybe she may answer some of your questions just after that, if there's time. I would like to thank you again for this wonderful talk. And
my pleasure. Thank you so much. Thank all of you. My apologies for running over. I hope you'll have more questions for our wonderful session 2C speakers than for me, but I will be there.
Thank you, Barbara. Thank you, Sanem. Okay, so now we are going to actually have a 15-minute break. But before you go, I want to mention, similar to yesterday, we're going to share a link in the chat. Are we sharing that right now, James? And this is what will take you to the next Zoom breakout meeting. So it's not actually in this session, but we'll share the link. You'll go right there. There will be a list of the breakout sessions for you to choose from. And of course, if you have any questions, just shoot us some questions here in the chat, or in the other meeting, you can also shoot us some questions. So it should be fairly seamless. But yes, please take a break, and we will start the breakout sessions at 3:15. Okay, there's the link. It's in the chat box.